StarTimes on app kwa burudani kemkem wakati wowote popote ulipo. StarTimes, furahia maisha kidijitali.
And what are your expectations for today?
Hello, my name is Julie Tarode. I am British, but I live in Switzerland, and I'm on the board of Kalele Health Association, which is an NGO here in Kenya. I am very excited about the groups coming together today, so I'd hope that we all go home with a better understanding of each other and that we are very committed to working further together on this issue.
Great, thank you, Dr. Julie. Would you, please?
Hello, good morning, everyone. My name is Karen Nakawala, and I am a cervical cancer survivor. So being here today, I think is a glimmer of hope that we are able to eradicate cervical cancer. And I speak from a point of authority when I say that this is not a disease that you would wish on anyone. And the sad part is this disease is preventable. And so us getting here together, I would like to see outcomes that will ensure that no woman has to go through what I did and no woman has to die needlessly, and that the young girls are going to be protected and have a cervical cancer-free future. So thank you.
Amazing. Please, round of applause for every single person who has given us their expectations for today. I think I'm very excited even the more because now we get that every single person who is here is very passionate about the conversations we are about to have today, yeah? Yeah? Yeah. So now that I have gotten a few of your expectations, here is what you will be expecting. For these 3 days you will be here, right? So we are having the theme, okay, is uniting faith and science to eliminate cervical cancer in Africa. So that's the conversation we'll be having right here at the Nairobi Convening on cervical cancer and HPV vaccination from today to the 13th of June. Now, if you can look through your program as we just go through it together. Now, day one is today, which is going to be us just having a conversation on what are these issues, yeah? Are we going to identify these issues? And it's going to be in 3 parts. Morning, afternoon, and evening. But before I get deep, I'll just give an overview of day 2, which is judging the problem now that we have identified it, and day 3, action planning and way forward. Now, I won't talk about day 2 and day 3. Let's look at day 1. In our morning session, we'll open, then we'll have a keynote address, and then a panel discussions. We'll be having about 3 panel discussions. Then with an afternoon session, we'll have breakout sessions. I believe we also have an online audience joining us, and they'll also have a breakout sessions. And I believe every single person knows what breakout session they will be going to. Yeah? No? Then that will be addressed. Don't you worry. And then we'll have a plenary after breakout session. Now in the evening, downtime, and networking dinner. So that is what you are to expect. And of course, as Dr. Julie and Ms. Karen said, we have a lot of genuine conversations that we're going to have. Leaving here after these 3 days, we should expect that we have identified, we have analyzed, and we have found a way forward when it comes to elimination of cervical cancer when we combine science and, come on now, science and what? Science and faith, and that is why we are all here today. Now, without any further ado, we'll go to the opening session. And I'd like to have messages of goodwill from the partners and key stakeholders from the faith community. We'll start with Sister Regina Nthenya, who is the Health Associate of Sisterhoods of Kenya. So please, Sister Regina, karibu sana, welcome.
Thank you. Good morning, everyone. I think I have a lot of excitement until I have butterflies in my stomach. So you could be praying for me as I talk so that the butterflies do not choke me. I start with a short story. very short. I know most of us have heard this story, but I wish to repeat it for another time. Please bear with me. There is this boy who was supposed to shepherd sheep for the master and was sent to the field with the sheep. And he was to stay there with the sheep. And he was given an instruction. Please, anytime you hear the voice of the fox or you see the fox, please shout so that the community can be able to help you and save the sheep. So the boy stayed the first day. Another day, there was no voice, there was no sight. And I think somehow, being a boy, he was ready to explore and said, why can't I shout and see what will happen? And he shouted, fox, 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 please come and help. And the whole community was there coming to help. There was no fox. They went back home. They imagined the boy is afraid. So, seemed like he enjoyed that. The second day, he never had anything, he never saw anything. He shouted the same, and the whole community came. There was no fox. He enjoyed, he went back. Then another day, there was a real herd of fox. And he shouted, and nobody came. He shouted, and nobody came. And by the time the community knew it was true, they could hear now the cries of the sheep. By the time they came, the animals had already destroyed quite a number of sheep. I stop there with the story. The rest, you can pay airtime for. I want to say we are writing a story that might have started long time. And you see the story begins. The story has a flow with a lot of turns and twists. We know those who follow the soap operas, how it looks like, and the movies. And everyone is always looking at the happy after. So for me, I know this is a story we are writing, and my high expectation is that happy after moment, whereby we are going to say, yes, we have been there singing about, I don't want to go back to the story, but here we are now, and we can do something for ourselves. I'm saying for ourselves because anything that affects a family member will affect the whole family, will affect the whole society. So in fact, we are not talking of Kenya, we are not talking of Zambia, we are talking of Africa. Africa. This is the time we need to stand up for ourselves and do good to ourselves. Let us do that wholeheartedly. Let us give ourselves to this. Let us commit. Not only talking, let us commit. This could be the best time for ourselves. So I want to appreciate Father Charles for this noble task. Thank you for accepting to forge ahead. There must be a leader who clears the bush, who gets stuck in the mud, and we have a path to pass through. So thank you very much. I welcome each one of you. I'm so happy to find the kind of group here, representation. It's a high level, and this is the time when we are not saying, what am I doing good? What am I doing better? It is a time we are talking of what are we doing better for ourselves? With that, I want to stop there and say welcome all of you and wish you a good stay here in Kenya. We love you all. Make sure we do not retain here illegally. Thank you.
Thank you so much, Sister Nthe. And those are amazing words from you, you know. This is a very high level. In case I forgot, my bad, but this is a very high level meeting where we have experts from the whole field. You know, in the medical field, we have Professor Mulindi here, who's told me he's a cancer doctor, and I'm just like, whoa, you know. So you're amazing, amazing, each and every one of you, and some are from Zambia, and from, you know, West Africa, and from, you know, everywhere. So we have the powerhouse right here. So thank you, Sister Nthe, for the beautiful story, which is a very, I'm sure we've had it, yeah? But now in this context, it's very important for us to also just get to hear it again. Now, I'll get to Imam. Now, if I butcher this, please forgive me. I am open to be taught. Imam Alido Ibudo, please do come and give us a good message of goodwill. He is a Muslim religious leader from Burkina Faso. Please, round of applause as he comes on. Karibu.
Assalamu alaikum. Que la paix de Dieu soit sur nous tous qui sommes rassemblés ici. Voilà. Oui, il a commencé depuis l'avion.
Yeah, may the peace of God be upon you who you are meeting here. We met in the airport, so we are now friends.
Donc je disais que je souhaite la paix de Dieu sur nous tous qui sommes rassemblés ici.
So I'm saying that wishing the peace of God be upon you, you all we are meeting here.
Je commence par louer l'Éternel qui nous a facilité cette rencontre.
I start by praising God who has helped us to meet here.
Et je voudrais aussi louer les circonstances et les hommes qui l'ont organisé.
I would like also to praise people who have organized this.
Pour moi, c'est une grande joie de me retrouver, vous, et surtout cette communauté des Jésuites qui a fait un grand apport à la science mondiale.
So for me, it's a great pleasure meeting you guys, especially Jesuits who organized this thing for us to meet here.
Je sais que les réflexions seront très pointues et c'est aliment de la communauté.
And I know that the reflection here will be very high level, and in the image of this community.
Notre rencontre est une rencontre essentielle, une rencontre de vie.
Our meeting is very essential because it concerns the life.
Nos filles, nos mères, nos sœurs, nos épouses souffrent pour donner la vie et beaucoup y laissent la leur.
Our daughters, mothers are suffering to give life. So we have to think about that.
Tant que nous étions dans un monde où nous marchions à pied ou à dos d'animaux ou que nous buvions à la rivière, cela pouvait se comprendre.
It was a long time when we were living like animals, going to find maybe water in the river could be we can understand. But now time has changed, so we have to think about this issue.
Aujourd'hui, où nous sommes dans la communication instantanée, où la plupart de nous étrangers, nous sommes venus ici par avion, je pense que tout ce qui est humainement possible à faire pour la santé de l'homme et de la femme en particulier doit être fait.
This time around, with communication like us, we have come from using plane, and I think it's time for us to do something to address this problem, this issue of cervical cancer.
Et si aussi il devait avoir une conscience pour l'humanité et la préserver des dérives possibles de la science, c'est la communauté religieuse, quelle que soit l'acception que nous avons de Dieu.
And also, as scientists, we have to think about how to see where are the limits of the science to prevent, maybe bad use of the science, so that with the help of God, we can find a way of preserving life.
Et en tant que communauté religieuse, nous avons une éthique, nous avons des valeurs, nous avons de la morale. Mais la plus grande des valeurs et des morales, c'est pour servir la créature la plus célèbre de Dieu qui est l'homme.
So as maybe a community, religious community, we have to think how we have values, and the most important is how to preserve life. We need to think about that.
Donc, merci à la communauté d'organiser cette réflexion. Merci de permettre aux autres communautés, aussi bien religieuses, coutumières et traditionnelles, de s'éveiller à cette conscience qu'il nous faut unir, comme le thème le dit, la foi à la science pour le bien de l'humanité.
So we want to thank all the communities, traditional leaders, and ourselves, so that we can address this issue, how to think about life, how to preserve its life as a community of scientists.
Donc voilà l'essentiel de mon message ce matin, c'est d'appeler toutes les personnes qui luttent pour sauver l'homme de l'enfer, de l'au-delà, d'abord aussi de lutter pour le sauver des difficultés de ce monde que sont la misère, la pauvreté, l'ignorance, la maladie.
So we have to think how to save human from the hell by serving, by working together as a community, so that maybe tomorrow will be good.
Je pense que je m'arrête ici pour laisser le temps aux éminents professeurs et à tous les planificateurs de nous aider pour la santé de nos mères et de nos filles. Et je vous remercie encore d'être ici parmi vous. Que Dieu nous bénisse tous.
So I'm just stopping here. Time to listen to this big professor, high professor, so that together we can do something. So God bless you. So just one word. Myself, I was not, supposed to do the interpretation. My name is Father Pierre. I'm a Jesuit, medicinal chemist. So I'm happy to be with you. Thank you very much.
Thank you so much. Sorry. Merci beaucoup. Thank you very much. This is about life. If there's something we need to remember from what our Imam has told us, that this is just not data, no. It also involves life itself, and life is very precious. We need to preserve it. Now, I'd like to call Princess Tekaya Dlamini, who is a traditional leader from Eswatini, to come give us a message of goodwill. Princess Tekaya. Princess Tekaya. Amazing. Please. Karibu sana. Welcome.
Good morning, everyone. All protocol reserved. I'm a princess from Eswatini. I've been working with the UN Women and AUCF on young ladies. So this is my first time in a meeting like this one, but I'm willing to learn something from it because this vaccination will be good for the young girls. I'm very sorry. Yes. So I'm willing to learn something from this meeting, and I'm willing to work with everyone, and then I'll take something from what I've learned here and take it home. Thank you.
Thank you so much. We are here to learn. I am here to learn. Everyone is here to learn. Thank you, Princess Tekaya. Now we'll go to the next segment, so we'll have a message of goodwill from the community and survivors here. Miss Miriam Chanda Mumba from Zambia, please. Come, let's hear from you.
Good morning, everyone. My name is Miriam Chandamumba from Zambia. I bring you warm greetings from Zambia Interfaith Networking Group. I would like to recognize Dr. Patrick Amos, Acting Director General, Minister of Health, Kenya. From here, where we are, all esteemed organizers, all senior government representatives here, all protocols observed. Ladies and gentlemen, distinguished guests, it is a great honor to be with you at the Nairobi Convening on Cervical Cancer and HPV vaccination. This gathering represents a critical step towards addressing one of the most pressing public health issues facing our continent today, affecting women in particular. I am deeply encouraged by the collective effort of all stakeholders present here: religious leaders, health professionals, policymakers, and community advocates. Your commitment to this cause is both commendable and essential. The collaborative spirit demonstrated here gives me a great hope for the future, especially for our communities. By combining our expertise and resources, we can create impactful strategies that will save countless lives. I commend the Africa Health and Economic Transformation Initiative and all partners, organizations, for spearheading this vital effort. I urge all of you to continue supporting the people who are in need of your professional support, both the patients and the survivors. I encourage all of you to actively participate in the discussions and to take the insights and the strategies developed here back to our communities. We need your help. We have gone through a lot as women. You know, it is very painful to see a fellow woman suffering at home, especially in the community where they don't have facilities near. It's heartbreaking to see a fellow woman, especially when you go to the hospital, for the lack of knowledge and for the lack of fear. Because when they bring these problems to health professionals, they can be treated at the earliest stage. But when you see that a woman stays at home because of unknown fear, you don't want to come out and open up to the health experts to be helped. It's a very sad situation. Lastly, but not the least, I would like to express my gratitude to the organizers who extended the invitation to many other professionals and us from the community. I salute you. Thank you for your dedication and hard work. I wish you all productive and inspiring convening. And I look forward to seeing the positive outcomes of our united efforts from this gathering. I personally, when I get back to my community in Zambia, I know that a lot of women will come out and they will speak out and they will find a way of accessing the professionals who could help. Because if we live with that fear, then we'll get nowhere. You'll find a woman who is a pillar of the family dying, leaving the children as orphans. It's very painful and it's heartbreaking. We are here to learn a lot of things from the experts. We are here to get encouraged from the leaders, from churches and different societies. God will be with us and is going to guide us. The way we came here is not the way we'll get back to our community. I thank you very much. Ziko momaningi, asante sana, tuko pamoja.
Tuko pamoja indeed. Thank you so much. Wise words from Miss Miriam, talking about overcoming fear and just giving us hope. Now, Miss Pamela Savai is a cervical cancer survivor from Kenya, and I'd like her to come here and give us a message of goodwill. Karibu sana. Round of applause as she comes.
God is good, and all the time. Amen. Thank you. My name is Savai Pamela. I'm a cervical cancer survivor under the Kilele Health Association. I have a story too. 5 years ago, 2019, January, as we all know that January is the Cervical Cancer Awareness Month. When I was passing on the road, I saw posters. There's an organization that had organized free cancer screening. I was a very healthy woman, no signs of any sickness, so I just thought in my head, I know I don't have cancer, but I'll just go and try to screen. So I went. It was on a Sunday. I remember I'd clothed to go to church, and I believe it was the Holy Spirit that led me to that. I came to learn that later. So I went to Uhuru Park, just in the city of Nairobi here, for the screening. The guys who did the screening called another one. I asked them on the spot, why are you calling the nurse? Do I have cancer? The guy was like, no, we are seeing something, so we just have to call an expert. The nurse came and I was told you have to go for a further test. I went to do pap smear. After pap smear, I went to do colposcopy. After that, I was sent for biopsy. It came out that Pamela was having cervical cancer stage 1A. I had just buried my husband 2 years ago, so what did I see? I saw death. I saw leaving my kids all alone. I was frustrated, devastated. I was anxious, I was lost. But then, someone, a survivor, talked to me, And the doctor who did biopsy to me, God bless him, he told me, Pamela, you should really thank God. This thing has been realized at a very tender age. So you're going to do your surgery and you're going to be good. The only thing I have to urge you to do, you have to believe and trust God. He was a Christian. I remember one night I just knelt down and said, God, I'm surrendering everything to you. And true to his word, I went for surgery. Another biopsy was done and I was declared cancer-free. And recently I did my 5-year test and still no cancer. I give all the glory and honor to God. So during my journey, during the COVID time, I met Benda, but I met Benda during she was the one actually from the other organization that had organized the free screening. So we knew each other from that. So during the COVID, I think we were so bored and she was like, why can't we make up a group of cancer survivors and see what to do? So we came up with that group and we started. She said that we have to do hiking. I was like, how? We are delicate people, we are special people, we've gone through surgery and the chemo. These bodies cannot go up the mountain. But we said we want to take the journey of the treatment now into the physical thing. So we started hiking, and I'm proud to say that through God's will, I've hiked Mount Kenya thrice. Going up to the summit, I've done Kilimanjaro. There was a time we were doing funds for the newly reorganized. And Benda, please organize. We get sponsors. We want to go to Everest Base Camp. But we promise we'll have to carry oxygen. So when I was going through my journey, one verse that I stood with was that I will not die, but I shall live to tell of the goodness of the Lord in the land of the living. So this is why I came out to do advocacy and creating awareness. Why? I realized that cervical cancer, many people in my community or in my country do it secretly. Because I remember the first time I did an advert on the TV, some of my friends called me and told me, Pamela, why did you decide to go public? Why do you have to admit that you have cervical cancer? I said that that's a vow I made to my God, because it's not that I didn't have money. So it's not that I was saved because of the money, but I believe God saved my life so that I can be a hope to someone. And as you know, human beings, we like seeing an example. So my life, having gone through the journey of the treatment of cervical cancer, because many people term cancer as a death sentence, so I had to come out, speak out. Even if you want, I show my scars. I show you my papers. I tell you this is the hospital that I've gone to. This is what I've passed through. And look, through the help of the doctors that God has inspired to treat, God has healed me. So I go out, speak it out. I preach about cervical cancer and HPV vaccine. I'm a mother of 2 girls. And after my treatment, the first thing, the best gift I thought I should give to my daughters was to take them for the HPV vaccine. And 2 of them got the 2 shots of the HPV vaccine. So what I tell everyone, parents and caregivers, is that HPV vaccine is as safe as any other vaccine that we give to our kids, the polio, measles, and is very effective. What a joy if you one day wake up in the near future and get that we have completely eradicated cervical cancer. Cervical cancer is one of the cancers that can be prevented. How? Through the HPV vaccine. It's cancer that is treated, especially when it's captured at an early stage, and it's also treatable. So I go out telling women that you have to go for screening. If you're above age, you go for pap smear. If it's gotten earlier, as it was done to Pamela and to many others, because I know of many others, even in our group we saw nurses treated the lesions, which has not yet even developed to cancer. And I'm very grateful that people are now going for the screening. So if it is captured earlier, the cost of the treatment, as we all know that cancer is a very costly disease to treat, you save on the finances. Also, chemo is tough on our bodies. If it is captured early, you don't have to go through chemo. Like myself, I only did the hysterectomy. I didn't have to go through chemo. So, as the Bible says, my people suffer for lack of knowledge. Please, let's embrace this. Let's educate our people on the goodness of going for screening, on the goodness of the HPV vaccine. We demystify this thing that the vaccine is that sterilizes our girls, and it's not. I remember when I was a teenager, there's this vaccine that we used to get. Was it for tetanus? I got like 3 shots, and some people are saying that, oh, you can't give birth, it will bring infertility. But I think it's just a lie, and maybe people don't know the truth. So no woman should die of cervical cancer. No, we should not lose our generation because of cervical cancer. And we know the burden that comes along when losing a woman, because we know mothers are the pillars of our families. As the father goes away to find for something, it's the mother that is back at home organizing and with the kids. So please, let's embrace this, the HPV vaccine, the screening, and everything, so that we don't lose any woman due to cervical cancer. And I really thank the civil society organizations, because they've been really drumming this, and I'm so proud, and I can say is a prayer answered when our churches now join us, because now we see people will really believe in this, because some people like, oh, my church doesn't advocate for this. And we know in Kenya, 80% we are Christians, so when we hear it from the clergy, we'll really hold on to it. And thank you so much. God bless you all. Karibuni.
An incredible story of hope, right? And what really struck me was how faith plays a role in it being a driver of hope, which is amazing. Thank you so much for being bold enough to just not only share your story, but also advocate, and tell cancer survivors or cancer victims that, hey, you're not alone, right? Yeah. Thank you so much, Ms. Pamela Savai. We'll get to the next segment of our program, where we'll get keynote addresses. We are expecting Dr. Patrick Amoth, who's the AG Director General for Health, Ministry of Health, Kenya. So we're only going to get a keynote address from Father Germain Rajo Lison, from Symposium of Episcopal Conference of Africa and Madagascar. Father Germain, please. Karibu. Round of applause as Father Germain? Oh, over there, okay. Karibu, welcome, welcome.
Good morning, everyone. Before reading my text, I would like to thank, on behalf of SECAM, Father Charles for inviting me to participate in this workshop. I wish him and his team and Jenna every success to their activities. Thank you, Father. The title of this communication is Uniting Faith and Science, a synergistic approach to eliminate cervical cancer in Africa. The Director General Health at the Ministry of Health, ladies and gentlemen, esteemed colleagues, and cherished members of our faith communities. It is with a profound sense of responsibility and urgency that I address you today at this pivotal convening in Nairobi. As the head of social justice at the Symposium of 4 Episcopal Conferences of Africa and Madagascar, I am deeply honored to contribute to our shared mission of combating cervical cancer, a devastating disease that disproportionately affects our sisters mothers, and daughters across the continent. Today, we gather under the theme Uniting Faith and Science Against Cervical Cancer. This theme is not merely a call to action. It is a declaration of our commitment to harness the collective power of our spiritual convictions alongside the rigor of scientific inquiry to address a critical public health challenge: the burden of cervical cancer in Africa. Cervical cancer remains the leading cause of cancer-related mortality among women in Africa, with approximately 119,000 new cases and 81,000 deaths annually. These are not just numbers. They represent lives, potential, and the very fabric of our communities in the face of such very fabric of our communities. In the face of such adversity, our response must be both compassionate and robust. The role of faith communities. As leaders in our faith communities, we wield significant influence and trust. We are uniquely positioned to advocate for change, educate our congregations, and dismantle the barriers to healthcare access, particularly in rural and underserved areas. Our moral and ethical teachings call us to act as stewards of health and life, making it imperative that we lead initiatives that promote HPV vaccination and regular screenings. Collaboration with health experts. Our efforts must be informed by the latest scientific research and best practices in medicine. Collaborating closely with health experts will allow us to disseminate accurate information, counteract misinformation, and ensure that our advocacy is grounded in evidence. It is crucial that our approach respects both the dignity of every individual and the scientific truths that guide effective medical intervention. A call to sustained action. The discussions and outcomes of this convening should transcend the confines of this event. We are tasked with formulating strategies that are culturally sensitive, sustainable, and capable of being scaled up. This involves developing training programs for community health workers, engaging in policy advocacy to secure government support, and implementing monitoring systems to track progress. Empowering our communities. Our ultimate goal is to empower communities to make informed health choices that will lead to the reduction of cervical cancer incidence. By providing communities with knowledge and resources, we foster environments where preventive measures are not only available, but also embraced. In conclusion, as we move forward, let us be guided by a spirit of empathy, collaboration, and unwavering resolve. Let our faith inspire our actions and our knowledge shape our pathways. Together, we can challenge the status quo and change the course of health in Africa, ensuring that cervical cancer no longer steals our mothers, sisters, and daughters from us prematurely. Thank you all for your commitment to this noble cause, and may our efforts be blessed with success and sustainability. Thank you for your attention.
Thank you, Father. A declaration to commitment, a call to action. Thank you very much. Round of applause. We're getting into our panel discussion now, where we will have an overview of cervical cancer, and HPV vaccination in Africa, and WHO 90-70-90, which is an ambitious strategy when it comes to combating cervical cancer in Africa, yes? So I'd like to call upon our moderator, Dr. Christine Sadia. A round of applause as she comes. The National Chairperson, Kenya Medical Women's Association. Dr. Christine Sadia, please. She will also be welcoming the panelists as well. Dr. Christine. Dr. Christine. Okay. So as we figure that out, I'd just like to give you an overview of what this session is going to be about. Now, there's an elimination strategy by WHO. Some of us are well conversant with it. The 90-70-90 strategy, right? We're going to delve deeper into understanding what this 90 means. Is it a percentage? Is it a number? And who does it address? What group of women or girls does it address? What about this 70, you know? And then what about this 90 when it comes to receiving treatment, vaccination, and screening, you know? Yeah. So we'd like to understand why it's important in this session where we are trying to identify these issues. Why is it important to talk about this strategy by the World Health Organization? Yeah, so. All right, then in the meantime, I'll call the panelists to join us. Dr. Paul Bloem, please, welcome. Sorry? Oh, virtual. Oh, great. We also have virtual participants. Sorry. Yes, so Dr. Paul Bloem is a senior technical officer at World Health Organization in Geneva, and he's going to be joining us virtually. Dr. Sharon Kapambwe, Cancer and Other NCDs Program Management Specialist at WHO, Afro, who will also be joining us virtually. Dr. J.P. Bohr, Head, National Cancer Control Program, Ministry of Health. Welcome to the panel. Ms. Jane Kariuki, Communications Development Expert, UNICEF Kenya, welcome. Professor Nelly Mugo, Kenya Medical Research Institute, Camry, welcome. And Dr. Paul Kamfor, who is National Coordinator for Cervical Cancer Programs in Zambia. Welcome.
Thank you. Ladies and gentlemen, thank you I will be your guide for the next 1 hour, and thank you. I would like to take this opportunity to just say I'm Dr. Christine Sadia, a member and the founder of Kenya Medical. The mic. You need a mic? Oh, good. Thank you. Is it able now? Like I had started by saying, we thank God for His grace this morning. I'll be your guide for the next 1 hour. And thank you for allowing me to be here for the next 1 hour to guide this session. I think it's a very critical session that we are going to take. I said my name is Dr. Christine Sadia, a member of Kenya Medical Women's Association and a founder of the same, a past regional president for, vice president for Medical Women International for Near East and Africa, which has just passed by. I am looking for my remaining panelists. Who is not? Who am I missing? Who am I missing? I have two. I know Dr. Kapambwe is online. I know Paul is online as well. So, Nelly, Nelly, you are part of us. Nelly is actually a member of Kenya Medical Women's Association, so it's part of us. Thank you very much. Paul, I didn't get your bio, so I'll give you to introduce yourself. I want to be as inclusive as possible. I want to start by, this session is for me a critical turning point. I would like to say that, where faith meets with science. I remember my journey in All Africa Conference of Churches at the beginning of HIV and AIDS, when I held the summit, the church leaders summit of all the bishops, when the denial was too huge and we could not make a breakthrough. And then I remember my journey also taking women to Beijing as a young executive of All Africa Conference of Churches. So I'm part of the church community and a part of the medical and scientific community. What a beautiful thing to look at. They are strengths that both will bring, and they are where we will synergize. For me, this is a turning point where we need to look at what will be the action that we come out from. For me, I'm looking for the action moving forward, how we re-energize the region and how we take it forward. So thank you very much. I would like by starting to introduce, I don't know if she has a mic already, I give them the opportunity to introduce themselves, but I could also do the introduction. Sometimes I give the power for people to say what they think that they would like to say about themselves. But that notwithstanding, let me take this opportunity to introduce the two that are online before I introduce Nelly. And I want to take this opportunity to introduce Dr. Paul. Dr. Paul is the National Cervical Cancer Coordinator for Zambia, then the Ministry of Health. He doubles also as a consultant in the Division of Gynecology, Oncology, and Cancer Disease. That is not Paul. So they have mixed my two things. Bloom. Can I have the Bloom one? Can I have the resume? I think I do have it somewhere. But let me start. Dr. Paul, you are God chosen. You have been the most, you've started. So thank you very much. So we will finish it. But let me start by my sister, Dr. Kapambwe, who comes from Zambia and is also a member of Medical Women International Association of Zambia, and a WA regional officer who has done a lot of work in Zambia, giving us technical guidance in the region and coordinating quite a number of things. She has been a first in many, and right now we have the privilege of having her here to talk to us as a regional technical advisor. I'm sorry about that, don't worry about it, because my computer is not with me and therefore it gives me a challenge a bit. Prior to joining the WHO, she had done a lot of many things in Zambia, managed to get many women to be screened, 50,000 of them at some point, in one point, and accelerated the points to be at 200,000. And then she led to the introduction of HPV vaccination, both in Zambia and in Africa. What a wonderful woman we have today to just give us a snapshot. And from this session, what we are going to do is to set the ground from the strategy, the global strategy 1970-90. So they will speak to 1970-90. But what is very instructive is that we are losing 4 women. If you have looked at the strategy, and I hope we have, it is very critical for us. And how many are we losing per minute? There are quite a number, 23 per minute. So it is not an easy matter. It is a matter that we want to take with a lot of weight that it deserves. So thank you very much. Dr. Bloom, you will be setting us because you are giving us the, Sharon, because you are giving a regional perspective. Dr. Bloom will give us the global perspective because he works in WHO Geneva. He has been instrumental in HPV vaccination, and in fact, that is where he's leading the globe. So what a wonderful person to meet. His resume, I would request the IT that you put the resumes of those people so that we could leave them for ourselves as we even go through what we are going through. Dr. Nelly, I do not know what to say about you, but I know I have a lot to say about you, but I will shorten it for the interest of time so that we spend more time in the work that we want to do. Dr. Nelly is one of our own, very well grown in Kenya. And what we know about Dr. Nelly is an obs and gynecologist. And from there, she's a renowned scientist in Cambridge. And she's the director right now of leading a department that is so useful that we cannot even miss out on that. So if she doesn't give us the pilot on how to pilot ourselves in this country, the issues of policy and research, the evidence is very critical. And Dr. Nelly will speak to a wealth of experience. We know you as somebody who has been in a lot of research when we are doing the microbicide. You were there with Kenya Medical Women's Association. You've gone ahead and overtaken some of us who are a little bit lazy and sluggy. So she has a lot of wealth of experience in Cambridge. She's leading a department, and she has championed a lot of research, including the one that we'll be talking about, the HPV vaccination, which is now taking us to the single dose that we would like to give women. That then is going to be a game changer. Already the policy is out. She will tell us how they did that policy. That is going to be a game changer because the loss to follow up when you are asking girls to be vaccinated to come a repeat recall is then going to be minimal. So I take this opportunity to welcome my panelists. I have a very enlightened and distinguished panelists. And from their resume, if they will be shared, you will be able to see that we are talking of giants and heavyweights in this particular subject matter that we are tackling. But let me take the opportunity and humility to acknowledge the religious community because it is not easy to bring people at this time. There are myths that people thought about, and yet they are the first people that get to our clients before we see them in the medical field. The community, like I saw here, ladies who have lived the experience. We cannot work on this field without the champions and the experience of people who have lived the condition, because who then knows better where the shoe pinches. So thank you very much. I would like to start, if we can get Paul to be given a mic to start off this session. Are you okay? Okay. So Paul,
yes, I'm okay.
With all humility, can I kindly call on you to start your session? Please take a 10-minute. If you could do 10, maximum 12, and then all the panelists will be given to present, then we will ask some questions. Thank you very much.
Thank you very much. Let me first check whether the sound works properly. Can you hear me? Can someone make a sign? You hear me? Okay.
It looks like the guys in the conference cannot hear us.
Okay, so let's...
Can hear you.
Can you hear us?
Yes, very well.
Oh, thank you.
Thank you very much.
We can hear you.
Thank you very much. So it's really a pleasure to be with you in Nairobi today. Let me start by thanking Father Charles for the invitation to be with you all. It was very moving to listen to the survivor when we started, and I think it's absolutely the appropriate way to think about this problem and to start with, you know, the people who will live this, which are the women. But of course, we also have to think of the girls who will need to be vaccinated. So it's really my pleasure to be with you. I work in the vaccination area in WHO, and I'm part of the group that looks at the global strategy towards the elimination of cervical cancer. So with colleagues who are specialized in the area of screening and treatment of cervical cancer. I heard the chair talk about the global strategy, the fact that most of you know what we're talking about. The 1990, that's nice, catchy phrase to think about the strategy. But I will dive in a little bit more on the vaccination. And in the vaccination, we're talking about 90%. We need to reach 90% coverage with the vaccine. Now, those of you who have your children vaccinated for DTP, for measles, you may be aware that typically for vaccines, for all vaccines, we are invited to take the vaccine, and we reach coverages that are typically very high. So most vaccines reach a coverage globally even of around 90% for DTP and polio and measles. So that in itself is something that we can do. So what is the challenge for HPV? So let's first start with this vaccine. I think why it's such an important vaccine. I really liked the word that I heard this morning, which was the goodness of this vaccine. And I'm pretty sure that Dr. Nelly Mugo, who's really, you know, not only a brilliant scientist, but also a local champion, as you were saying, can attest to that this vaccine is really good. Not only are its effects very, very strong, it's a very safe vaccine. And, you know, we have learned over the last couple of years that when you use this vaccine and you give it to girls very early, the effects are very, very good. So first, to go back to that part of early, we need to vaccinate girls. They are the main target for this vaccine when they have not been exposed to this virus. HPV viruses, technically, they are viruses of the skin. They like skin that are more mucosas. So we find them more in the genital tract. We find them also in the mouth. And they can create a series of cancers. They can be cancers of the head and neck. They can be cancers of the genital tract. So there's a lot of prevention that can be done by preventing HPV infections. And so we've learned that when we vaccinate girls very young, then we can prevent nearly all cases of cancers. So recently, I just give you a piece of data. We had long-term follow-up in one of the first countries that introduced this vaccine, which was in the United Kingdom, in England, and they have very good cancer registry. So they could follow up the women and the girls that were vaccinated when they were young, and they are now reaching towards 30 years of age. So we start to see the first early cervical cancer cases. Those who were vaccinated at age 12, 13 were more than 90% protected, and some studies even saw a protection of around 100% against cervical cancer. And so really, this is the evidence now that the vaccination prevents the infection. It's a vaccine that prevents the infection. But by preventing the infection, in the long term, we prevent the infection to mutate into a precancerous lesion, the ones that can normally be treated and that can thereby prevent cancer, or to move 15 to 20 years later to full-blown invasive cancer. So that evidence really is now, has made the whole evidence base quite complete. We know the vaccine is effective. it affects against the infection, but we also now know it really prevents against the cervical cancer cases. So we have modeled that when we reach the 90% coverage in the countries around the world, we can save 45 million lives of women in low and middle income countries alone in the next 100 years. 45 million deaths. This is enormous. And this vaccine, therefore, by some, such as Gavi, has been identified as among its most effectful vaccines. That's why everyone is really intent of introducing the vaccines in all the countries, also all the countries in Africa, and to reach high coverage. So maybe take a minute, like where we are in Africa. By now, 28 countries have introduced, and many of these countries have introduced with the help of Gavi, such as was the case in Kenya some years ago. And so we are really starting to see that the vaccine is expanding on the continent. There still is a way to go. Last year we had Nigeria that introduced. We now also have the good news that the DRC is planning to introduce in 2 years' time. So this means that the population of girls, and we know many of them in the region are living in Nigeria and in DRC, is now starting to get access to this vaccine. So that is very good news. We still have some countries to go, but we know many countries are making plans to introduce. Then, of course, we have the next stage. When we introduce, we need to make sure that the population, that the women, the mothers, understand what this vaccine is about, have trust in this vaccine, and use this vaccine. So I think, let's start with the good news. There were many introductions done in this region. We can, for example, think of a country like Rwanda, where the vaccine from the start at the national level has been very well received. And coverages have been very high. Nearly all the population, 80–90% over this last decade, have used the vaccine. So we have very good examples. And actually, when I look at the first years of when this vaccine was introduced in actually most of the countries of the region, we've seen coverages that are between 70, 80, 90%. So very good acceptance of this vaccine. So I think that's a very important point to establish, that overall there is actually quite good acceptance of this vaccine. It doesn't mean that the picture is rosy and has been rosy all the time. Particularly when we think back a couple of years, we think of the COVID pandemic. And that, of course, changed very much what happened. So in many countries, the pandemic made that schools were closed, that HPV was not delivered. We first focused on the most vulnerable young children. And only now we are picking up the vaccination of this vaccine. So yes, the HPV vaccination has seen a very important dent in many countries. And now there's the need to revitalize this vaccine. And this is a call that the WHO, together with UNICEF and Gavi, has put to the countries, and countries are responding. Now, there is also, of course, the issue of the fact that not everywhere is the vaccine well accepted, or not everywhere do we reach high coverage. And again, I think it's very important to look at these 2 points. There is, and we've seen that strengthened, if we want to say that word, during COVID, there is more discussion about vaccines, and there has been, we can say, some growing hesitance of the vaccine. Sometimes this is stronger in the urban areas where people have a lot of access to the internet, and they hear all the bad messages that are being said about this vaccine or other vaccines. And sometimes in the rural areas, there is much higher uptake. We saw this recently in Nigeria. The introduction in Nigeria has gone very well. coverages between 70 and 80%, according to the numbers that were provided to us preliminary, were reached in many areas. But at the same time, there were rumors going around, particularly in the capital of the country, and there the initial coverage was much lower. So this is of course what many of the programs are struggling about. This is where we need to talk to everyone. That's where organizations and CSOs are so important, to spread the word, to talk to the mothers, and to build trust. Trust is a key part that we use in our faith. It's also a key part that we use in vaccination. Trust is the basis for people accepting. Trust in the ministry, trust in the vaccinators, trust in the health workers, in the nurses. So this is what we need to strengthen and what we need to capitalize on. And I do think there is a lot of trust in many of the health workers in the region. So a big challenge that we have actually is one of having low coverage because an adolescent girl doesn't have necessarily the same autonomy as a mother has, or that an adult woman will have. So it means that girls, they are in the house, or they are normally where they should be at school. And therefore what we have found is that there's a very strong relationship between reaching the girl where she is, which is typically at the school. This is where we hope she is, particularly around these young ages of 9, 10, 11, when it's the best moment to vaccinate, and reaching high coverage. And this is unfortunately where we have a challenge. And the challenge is one that is bedeviling cervical cancer prevention in general. It's one about inequities, it's about resources. Do we put in, we as governments, as administrators, do we put in enough resources for our health workers to go to the school once a year and offer the vaccine? When we do that, we can get very high coverage. This was shown in Kenya as well when they did an demonstration program. But of course, it does take more resources. So we think that these resources are very well spent, not only by reaching girls and enabling them to be protected against this terrible disease. And we also know that, of course, there's a link with HIV in the sense that when you have HPV, you may be more vulnerable to contracting HIV. You may be more vulnerable to developing cervical cancer, and much earlier. So it's even more important in countries in Africa where HIV is still a problem. And these resources spent into reaching adolescents at school are actually something that we need to do anyway to strengthen and improve the health of adolescents. They need a lot of inputs on nutrition, information about healthy living, information about diet, many things, including about their prevention of HIV, and they need vaccination, they need deworming tablets. So all these structures actually are needed anyway to improve the health of adolescents, including their future health as women that will be free of cervical cancer. The next generation can be free of cervical cancer, but as societies,
And on top of that, we see that there's an estimated number of deaths due to mental health and substance use, mental and substance use disorders increased steadily in our region, as you can see by those two maps. And just to add to what Paul was talking about, that we are trying to see people in an integrated, people-centered approach. Even girls, he talks about they come for vaccination, we give them deworming tablets, we want to give them information about HIV. It's also the same that we are seeing we should be aiming at as we are looking at non-communicable diseases, including cancer. This will avoid us avoid duplication effort, maximize our synergies, prevent and treat diseases with shared risk factors, and increase efficiency, so that when a woman comes, we take an opportunity to see her as a total human being and not split into diseases. And now I will zero in on cervical cancer. This is the incidence, the new cancer cases as of 2022, the latest data we have. And I must mention that 18 of the countries in top 20 of the highest burden of cervical cancer is in Africa, in our region, as we can see. And we can see in Southern Africa, you can see the colors. If you're looking at the colors like I am seeing it, sometimes it's different on PowerPoint, is that the deep blue are the highest incidences, new cases that we are seeing. And we can see Africa there, where we're seeing Mozambique, Malawi, Zimbabwe, Tanzania, Uganda, and we can see Guinea, Eswatini, as well as Lesotho. So 18 of the countries with the highest burden in the whole world are in our region. The next picture speaks a lot. This is about the deaths that we're seeing in 2022, the mortality rate. And now you see that mortality for the African region is the highest. Even where the incidence was a bit better, you see mortality is very high. And this speaks to lead presentation, inadequate access to services. So women will have the disease, but you see that most of them who come in with that disease are also dying, as you can see the contrast between the two maps. I think normally we talk about the burden of cancer, but we really never count the socio-economic impact of cancer. And there is what we're calling the generation harm, the issue of premature deaths and impoverishment. So we see that women are dying early, and they are also, some of them are within the reproductive age. We see majority of women coming in that age who are also contributing at family level and at society level in general. So what has been seen is that greater than 70% experience financial distress or hardship when they are with cancer, and greater than 30% of people affected by cancer and caregivers experience unemployment after diagnosis. And about 2.1 maternal orphans per cancer death are created. So cancer affects about 2.7 million women aged between 25 to 54 years old. And this is on a global perspective. But you also know that even in our region, this is the age where women are most reproductive, wise economically as well. And we have greater than 60% people with cancer experiencing anxiety or depression. And there's equally a GDP loss of between 0.5 to 2%. So when we think about cancer, we count the numbers, but we should also think about the socio-economic impact that cancer, like cervical cancer, which is the most common cancer the most common death, cause of death related to cancer in our region. So really, what has been the response on a global perspective, from the WHO perspective? We know that we have the SDG 3, which is ensuring healthy lives and the promotion of well-being for all at all ages. And we've got target 3.4, which talks about reducing 1/3 premature mortality from non-communicable diseases through prevention and treatment and promotion of mental health and well-being by 2030. In 2017, we had the World Health Assembly resolution, which talks about to integrate and scale up national cancer prevention and control as part of the overall non-communicable response. WHO has had global cancer initiatives, cervical and breast, and childhood cancer, and I will zero in on that. I think this is something we all sing, like Paul said, the 90, 70, 90. And really, Paul has given a great presentation on the first 90, and I'll talk about 70%, the 2030 target. 70% of women are screened with a high performance test by 35 years of age, and again, by 45 years of age. And 90% of women identified with cervical disease receive treatment. So 90% with those with pre-cancer are treated, and 90% with those with invasive cancer are also treated. I think I will skip vaccination, but this is the Africa progress against 90% HPV vaccination coverage. And I'm sure Paul might have the latest figures. This is at 2022. We were at 33% information, WHO, UNICEF, and our goal is 90%. So we're still at 33%. And when we come and look at screening, remember we're at 70% high performance tests. Only a small fraction of women on the continent have ever been screened for cervical cancer. As you can see from the various surveys that have been done, we have countries that are between 0 and 9%. If you look at concentrate on the African map, they're in the deep red. And when we have these are also taking about a third of the people are between 0 and 9%, and we're talking about 70% target. And then we have 10 to 19%. We still have some 20 to 30%, 35 to 49, and 50. So you note that in our region, there is no country that yet has achieved 70 to 89%, or indeed 90 to 100%. And we have South Africa, Botswana, which are showing to be between 50 and 69%. So as a region, and then I must hasten to mention that this is mixed. It's not with a high performance test. So if we come and now we're looking at data, trying to see where exactly have people, the countries are, if we're using high performance data, and that is going to drop drastically, because in our region, we do not yet have a country. And when I say our region, I'm talking about the WHO region, which is 47 countries, excluding most of the North Africa, South Sudan, and including Algeria is on our side. So you find that most of the countries have not scaled up. There are some initiatives of screening with HPV, particularly HPV DNA test, but these are all at national, some are at pilot level. So this was in this map took into consideration visual inspection with ascetic pap smear and some parts of HPV screening. So if we base it on high performance tests, this will probably be a very deep red map for Africa. I talked about mortality. When you look at mortality, you look at where the numbers are in terms of mortality and where we are seeing radiotherapy. We know that for cervical cancer, radiotherapy is important in treatment. So you will note that countries with a very high mortality rate do not have, if you look at Malawi now, I think they are almost opening. Though Malawi is number 3, we still see that there is actually no radiotherapy treatment going on. If we look at Zambia, even if we are seeing something, you will see that they have one radiotherapy treatment center, and Zimbabwe has some private, and there. So And then we see South Africa, which has the lower incidence, though it's also high by all global standards, but lower in our region, has a lot of radiotherapy machines. So the mortality and the availability of treatment in those countries are not coordinated. So we need to know that in the top 18 countries that we have, 9 of those countries do not have access to radiotherapy. That should be something that is, so we see the countries with no radiotherapy treatment that are listed there. And we know that Eswatini is the highest. We have Lesotho, we have Malawi, and all these countries, even though they have high mortality rate, they do not have access to radiotherapy. What are the key issues that we see in our region as far as cervical cancer is concerned? Is that our health systems are so inadequately prepared to address the growing burden of cervical cancer, with very limited availability of population-based screening, and there is inadequate access to treatment, like I have said. This is reflected in the shortage and uneven distribution of skilled and specialized human resource. We find that if we're looking at treatment, they're mostly centralized and mostly in the urban areas, even though the disease is widespread to the urban and rural areas, meaning there's inequity in the distribution of services, and the services themselves are not adequate. There's inadequate infrastructure, which we have shown. Pathology turnaround times are high in most of the countries, takes a long time. And that we're still using low performance screening tests, and WHO recommendations for screening talks about shifting to HPV testing. Financing, there is insufficient domestic funding, even donor funding, and what we have seen is most of the cervical cancer screening that is going on is usually piggybacking on the HIV programs. And studies have shown that women who are living with HIV, 30% of them have been, at least 30% have been screened, compared to only 11% of the general population. So there's high out-of-pocket spending. We just had a study coming out of Rwanda of financial toxicity of people living with cancer, with a high risk of catastrophic spending and people still continuing into the cycle of poverty. There's lab presentation. Majority of the women are presenting late. And this could be attributed to limited awareness and knowledge combined with fear and stigma, which leads to women seeking treatment late, and this leads to poor outcomes. We have weak monitoring and evaluation capacity at countries, even though we try to get data, but it's very, very limited that we get. And if we talk about late presentation, it's also that access to these, to HPV vaccination, to screening is limited. And it could be limited in that it hasn't been introduced, like Paul said, 28 countries have introduced. It could be limited in that our coverage in some of the countries is also low. What are the regional strategic actions to accelerate progress? We're looking at securing sufficient affordable HPV vaccination. This goes because most of the countries, as you know, and has been discussed already, look at affordable, but we have seen that there has been a drop in the price, but we also need to consider the delivery system. The campaign modes that most of the countries are on because of poor or limited school health programs. And that means that we go once in a while, and it could be costly both in time and it's labor intensive. And I will leave the vaccination because that Paul can come and delve much more into that. But there is need to improve communication and social mobilization, which is really what we're doing today. On the 70% of women screened with a high precision test by 35 and 45 years old. We need to understand barriers to accessing services and create an enabling environment, which is what we're doing, is one of the strategies that should be able to answer that question. I talked about integration in the beginning, integrate screening into primary health care. If a woman comes, she's checking, we must check her blood pressure, check her blood sugar, check her breasts, screen her. Let's see women in a much more integrated, holistic way. We need to promote screen and treat approach even when we're doing HPV testing. So we have to be innovative about how this is done. And we have seen countries like Malawi coming on board and trying to make sure that within 24 hours they can be able to use the HPV test that they're using to be able to give the results to the women, because there's a high loss to follow-up that we see. How can we ensure that we have affordable supply of quality-assured high-performance screening tests and treatment devices? And discussion, WHO, I know some of the countries that are in the meeting were involved in having discussions with the private sector. How do we reach that position? Strengthen our laboratory capacity to be able to give back results on time. We need to implement. Most countries don't have guidelines. How are they going to treat these women when they come in? What is the referral pathway? Expand our surgical capacity. Countries like Zambia that have been in the forefront and increase their screening, start seeing women much earlier, then we see that there's a need, and they have cancer which is amenable to surgery, but we have inadequate capacity. So those are things we need to look into. Improve access to radiotherapy. We need to optimize the workforce competencies. The people who are treating should be competent, and we have to improve on that. Survival care and reduction of cancer stigmatization. There's still very high stigma as far as cervical cancer is concerned. We need to look into palliative care as a human right. Only 20%, the latest statistics that we have is 20% of people can access palliative care. Remember, I said majority of the women are coming late, which means they do need palliative care to come in, but 80% of those cannot access that palliative care. And we need to have communication on what is palliative care and destigmatize palliative care itself as well, and make it much more accessible to the women who are coming in. I think this is my last slide. And once again, I thank you and looking forward to the discussion. Thank you very much.
Thank you. Very interesting. I think we couldn't have gotten a better person to give us what is in the region and what are the gaps, what are the challenges that maybe in the next session we'll be tackling or before we make the action. So thank you, Dr. Kapumbu. I would like to then call back to the stage, but before I do, please, if you have any comments, if you have any questions, those who are online, please put them on your chat, put them on your Q&A session. And I would like to say that there's one panelist who is on from UNICEF, who is online. We will be introducing her shortly. I don't know if, Nelly, are you available? You'd like to, Professor Mungo? Or I'll give your brother to go ahead, kindly. And take the opportunity to shower yourself with a lot of introduction. Don't feel shy. Just introduce yourself the way you know how. I know I've read now, and I know where I come from. He's an oncologist, he's in Zambia, he's doing great things as a consultant as well in the hospital. But I'll give him the opportunity to pat himself at the back. Thank you very much. Go ahead.
Thank you so much, moderator, and I would like to thank Father Charles Chilufya for the invitation. I'm going to speak about Zambia. First, I'm Dr. Paul Kamfwa, who heads the national program for cervical cancer under Ministry of Health. At the same time, I double as a consultant in the gynecologic oncology. When we talk about gynecologic oncology, we are trying to talk about a specialist who treats the cancers of the female reproductive organs. So if you look at what I do, much of the things is doing surgery for the women who come with cancers. At the same time, I also do the primary prevention, the secondary prevention, and the tertiary prevention. And I'm also a lecturer. I make sure that I lecture in clinical oncology. And again, we have got a school which specializes in teaching doctors in gyn oncology under the International Gynecologic Cancer Society. So I am the local supervisor for that. But this morning, what I'm going to talk about is the challenges, the successes, the barriers, and the opportunities that we have had with regard to the 90-70-90 strategy. And I'm going to look at it from the Zambian perspective. I think Dr. Kapambwe has highlighted much of that. So maybe let's just start with vaccination. For us in Zambia, we started a demonstration project somewhere in 2013 to 2015. And we started with 3 districts. When we reached 2019, we had to scale up and roll out to the entire country. And during that time, we had a very, very good success just at the outset. But down the line, especially in 2020 and 2029, of course, with the COVID issues, the vaccination coverage had to come down. This time around, we are at 64%. So when you look at Zambia, of course, there are 3 platforms that we use for vaccination. That of schools, in the community, and the outreach areas. So these are the platforms that we have used. And like what we mentioned, during COVID, remember schools had to close for about 8 to 9 months. So it meant that most of the girls could not get to the facilities. Again, facilities, the concentration during that time, it was those with COVID. And this had to hamper it had to bring down our coverage rate. But when you look at last year in September, we introduced what is called MAC. But before I go to MAC, we started vaccinating the young girls who were 14 years old. And by the time they reach 15 years old, we give them another dose. In other words, we were giving 2 doses. When a girl is 14 years old, we give dose 1, and when she becomes 15 years old, we give the second dose. Why did we start with those who were 14 years old? It was, of course, because of the vaccine constraints. But because of being a Gavi country supported, what has now happened is that we managed to receive enough vaccines. So because we were giving a single cohort, we then had to migrate to a multi-age cohort. Multi-age meaning that we take a couple of ages. In this time, September last year, we started giving those who were 9 to 14 years old. And the beauty is that instead of giving the 2 doses that we were giving, we only had to give a single dose. And medicine, literature has noted that a single dose is as effective as a double dose. However, those girls who are immune compromised, we have continued giving them the 3 doses. So in September, we started what is called multi-age cohort vaccination. And our coverage rate, it had to go to about 64%. So let me quickly now bring you to how did we succeed in that coverage. First of all, one of the things that made us to succeed, it's because of the good cold chain. Remember the vaccines, they require a very good cold chain, and this was at the national level altogether to the district level. And again, the other thing that made us to succeed in even to get that 64%, it was the good collaboration that we had with Ministry of Education. Remember, what happens is that these girls are coming from, or they are in schools. So you require to have a very good understanding and collaboration with Ministry of Education for you to ensure that you succeed. And of course, we had to come up with a communication strategy, and the communication strategy was to try to make the IEC materials, those IEC materials which were tailored to the parents, the IEC materials which were tailored to the girls themselves, and the IEC materials which were tailored to the teachers. And from the time that we started, we didn't have, in terms of the vaccine stock out. But what we have seen is that still we haven't done where we wanted to be, or we haven't achieved where we want to be. Why? It's because what we had started seeing when we were giving 2 doses, we were doing very well when we give dose 1. But when we go for the same girls to receive dose 2, there was a dropout. I think the vaccine group are going to talk about this, because this has become a challenge, and this was the biggest challenge. And again, the other thing was we had those data inconsistencies. So what we have done beyond that MSC is to ensure that we revitalize our strategy. And the goodness is that we want also to do the catch-up for all the girls that have missed that, and we want to routinize. If you look at what was happening, we were only giving the vaccines during the campaign period, and which was the Child Health Week. In Zambia, we normally have 2 Child Health Week, in July, in June, and another one somewhere at the end of the year. This is the only time that we were giving the vaccine. The sad part is if a mother wants to get a vaccine for that girl, and it is not during that period, the girls were being denied. This time around, routinization has happened, and I think maybe people from Zambia are going to speak about this, because there are some whose daughters have gotten that. And again, we want to strengthen the coordination that we have had with all the stakeholders. That is where we are in terms of the first pillar. Now, let me address the second pillar, which is the 70%. And when we talk about the second pillar, again, remember Dr. Kapambwe mentioned that we are supposed to use a high performance test. But colleagues, what we have been using in Africa for a long, long time is what we call visual inspection with acetic acid. This has been known like a very simple test, which is not expensive. What we mean by visual inspection with acetic acid, we take the same vinegar which we buy in the chain shops, and we put on the cervix, and just by using the camera, we magnify the picture. If there is a problem on the cervix, this is able to show. This is typically what Africa, the bigger portion of Africa, has been using. The other platform which Africa also has been using in some countries is using the pap smear. I think you have heard of this. Then we have got the HPV. Remember, what causes cervical cancer is the HPV. And because it is the HPV, you need to tackle that. No wonder WHO has said that it's better you screen with a high-performance test. VIA is not a high-performance test. It's not a high-sensitive test. The test which they are talking about is HPV. So, starting from 2019, as a country, we had to migrate from VIA to HPV, but this has been in a phasic approach. Reason being is that HPV is quite expensive. So what we started doing was that we started at 10% and we start graduating so that by the time it's reaching 2030, the target that WHO is speaking about, we are supposed to be at 20%. And of course, 70%. And of course, what we have been doing is in line with our National Cancer Control Strategic Plan. So where are we as at now? We are at about 40%. So what is happening is that we are increasing on HPV while we are reducing on VIA. So what are the successes that we have achieved in that second pillar? First of all, we have got a National Cancer Control Strategic Plan. Remember, like what she mentioned, if you don't have a strategy, if you don't have a framework, you don't know where you are going to go. It's better you have that. I know my time is almost running. Again, one thing that we have managed is, if you want to control your cancer, make sure that you have got a structure, because this is the only thing that is going to help you from the higher level to the lower level. What else do you need? You require a political will and the support of the government. You require the coordination from the implementing partners, the financing partners. Remember, we have got a lot of money which has to be spent, especially for HPV. What else have we done in terms of, again, the treatment? For us, we saw that treatment was a very huge and big problem. Ablative treatment, the nurses were doing well. But when it came to excising or removing that portion from the cervix, where what we call lip, it was a very big problem because it was like a preserve of the gynecologists and other medical doctors. So what we did was to try to bring this even to the level of medical licentiates, and the goodness is that we have started again, we have trained in the country about 9 nurses who are able to do that. With HPV, again, what we have started is, remember, cervical cancer is a community, or is a public community problem. And the only way that we can increase coverage is to ensure that we go in the community. So what we have done, started doing is community-based self-sampling. Because we know the woman has got that authority, she can do her own self-sampling and bring that to the hospital. We see that probably this is the strategy which is going to help as much as possible. And of course, we have made sure that we have integrated cervical cancer into the HIV services, such that when the woman who is going to come for HIV services comes there, first has to pass through cervical cancer. Let's look at these, colleagues. We have essentially said here, saying cervical cancer is a purely preventable disease. One thing, it's a purely preventable disease. The second thing, it is a disease which we can cure as long as we discover it in the early stages. And it is a disease which we can eliminate. 3 things. We are able to prevent, we are able to cure it, and we are able to eliminate. But if it is a disease which can undergo all these 3 things, why should we even convene here to try to talk about it being a leading cause of cancer deaths among our women? Remember, every 2 minutes that we speak, we lose a woman. And you know, we know what works, and we know everything. Why can't we do this? Finally, of course, I think during debate I'm going to talk about that because the moderator is saying, I think I've run out of time. I wanted to talk about the enablers, the challenges, and a bit of barriers that we have. Thank you so much, moderator, for the opportunity.
Thank you very much. Sorry for our time. I have to control time. We have still got 2 speakers and the time is up, actually. We are on grace. So because we are on grace and we don't want to minimize the time, it is inclusivity. I would like to call upon Professor Dr. Nelly to take up her stage. Thank you very much, Dr. Nelly.
Thank you. Good morning. I'm going to start by apologizing because I'm going to take you back to PowerPoint. So don't be afraid. I will not take a long time. I also just want to, I hope I have the right slides with me. I also want to say how excited I am this morning. It's the wrong one. Oh, my battery. Yeah. Could I borrow somebody's? Because no, I didn't think I'd need it.
Which one? HP?
No, I didn't think I'd need it.
Which one? Which make?
It's a C, type C.
Which?
I think yours.
Yeah. HP?
Even your HP type C. If it doesn't work, I can continue talking, no worries.
I think you want near my desk. There should be one near my desk.
No.
Thank you.
Sorry, yes, thank you very much. So I want to start, I don't know if, am I audible?
Yes.
I'm audible, thank you. I want to start saying just how extremely excited I am today, because we've convened here together, adding the community of religious leaders, the community of science, and the community of advocates. So I'd like to really appreciate the Jesuit community, Kelele, the advocates, visitors from the other countries. And it's a real honor to even start a meeting with a blessing from above. And also just listening to the advocates. And I'm going to try not to kill you with PowerPoints and with science. I think I've mixed up my notes a little bit. Oh, thank you. And I'll try also very hard not to repeat on the things that you've already heard this morning. And I'll try to emphasize perhaps some of the other things that we have not touched. I like to start by saying that cervical cancer is a disease of iniquity. And it's usually where resources are low that people are most impacted. And one of the stories I've always liked to tell is the story of this woman, Henrietta Lacks, a black woman who died from cervical cancer in the USA in 1951. And her cells, oh, it's not charging.
IT support in the room. IT support, please.
I'm not sure it's not charging. Yeah, one of the reasons, it's my computer is on. It's the connection, I think.
We can see your slides.
Oh, you can see my slides. Oh, fantastic. We're good. So I just wanted to say that it's really a disease of iniquity, and it's a reminder that it's those with low resource geographically and lack of access who are carrying the highest burden of disease. And Henrietta Lacks was one of those women who died at the age of 31. And women in our continent keep dying at that early age. So that story, if you Google her up, her cells are in use, they've created vaccines. And then we have the story about when HPV virus was identified as the cause of cervical cancer. Because we keep talking HPV, and until you know what causes a disease, it's hard to find what to do about it. So there was a Nobel Prize for that. And then I wanted to take us back and say we have achieved elimination. It's been possible because polio elimination has happened. But what made polio elimination feasible? I'm posing. What made it feasible? It was vaccination. It's vaccination. When I started medical school in the early days, measles was killing children in the ward because our coverage was low. Those of us who were a bit older, we remember the wheelchairs in town, on the highway, because of polio. But we don't see anybody with polio anymore. Our youth don't even know it, yeah? Children don't die from measles anymore. And I want to say that we will reach and can reach a time when women don't need to die from HPV. I think I need to stop sharing so I can see my own slides, because they're...
Recording in progress.
Oh, it's back. Oh, I see. But I can't move. Oh, there we are. So I've talked about the issue of iniquity. We've heard from Dr. Paul about the 3 areas of prevention, and it's primary. Primary is the vaccination. The virus, you don't even allow the virus entry, right? Because you're vaccinated. Then the secondary part is the one Dr. Kapembe talked about and Dr. Paul, which is screening for the pre-cancer disease and treating it. And it's done easily in the outpatient. And the third one is when you have the actual cancer and now you treat it. And all these things are feasible. We have the tools for them and the ability to implement them. All these interventions are safe, they're effective, and they've been proven to effectively prevent disease. Why is HPV so important? I just wanted to remind us that HPV causes 5% of all cancers, and it also affects men, not just women. It's second to H. pylori, which causes stomach disease and cancer. And then we are familiar with hepatitis and liver cancer. We have no problem with vaccination for hepatitis. I think I have an echo.
No, it was fine. Oh. I wanted to take the question. Go ahead.
Okay. But we have had a problem with HPV, and I think it's been alluded to, and we need to think about the things that are not allowing us to do this. So we have lots of HPV viruses, over 100, but it's about 12 of them. There used to be labeled 15, which caused most of the disease. Now, 85% of all HPV cancers are cervical cancer. That's what we're focusing on, cervical cancer. But I want to remind us that there are other cancers caused by HPV. Oropharyngeal, men get oropharyngeal cancers. There's penile cancer, and I say this in all due respect to the church. But if penile cancer rates were equal to cervical cancer rates, we wouldn't be meeting today. That vaccination would have happened, the prevention strategies would have happened. So if you go back to iniquity, it's an iniquity of women. The issues of women and where they lie when there's resource allocation, implementation, and advocacy. So let's keep that eye there. And only 2 HPV types cause 70% of cancers, and these are in the vaccine. And then the other types are in the other high-rates vaccine. I think Sharon spoke to this, that Africa, sub-Saharan Africa, carries the highest burden of cervical cancer. Globally, it's the 4th most common, but in our countries, low-middle-income countries, a number of them, it's a leading cause of cancer deaths. So it parallels between breast cancer and cervical cancer. So where there's intervention, you see, breast cancer is very high, but in our countries, maybe less death from breast cancer and more from cervical cancer. And I always tell this story. You ask people about breast cancer, they know where the breast is. Talk about the cervix. It could be a country, right? So even understanding what this cervical cancer is and where it impacts. We've also seen data shows that where there's low income, there's more disease and death. And the high income countries don't see the same. And it's not because they never had cervical cancer. It's not our behavior which is different. In the early years before pap smears and before they had national programs, those countries experienced the same cervical cancer rates that our countries experience today. But because they use the intervention and knowledge, they've been able to change this. A reminder, I've said this, that men are also affected. There's just higher burden in women. And we say if we vaccinate women, because most people are heterosexual, you have this thing called herd protection, so men equally get protection. So I'll not show you that data, it's a lot. I wanted to show you this as a reminder. We have a 10-year period from the point of getting HPV to cancer that we can prevent. We've known this for years. So we say stop the infection with a vaccine, right? A highly effective vaccine. Stop the disease, the pre-cancer, that whole period. We can screen and prevent it. Pick up the cancer early. We had the testimony early. Early stage cancer with a hysterectomy is curable, but we're unable to do all of this. And what does that mean? I'm going to skip this. This just reminds us about the social impact of the disease, the isolation, the psychological impact. I think we'll hear testimonies from the advocacy groups. The HPV is very common. I'm not going to this. So it's not so much, because every time we talk about sexual-related diseases, there's stigma, right? But if we picked HPV in this room, a number of us will have it. On a population level, we have up to 40% sometimes, and in other populations, it can go up to 70%. So we really need to move away from that platform. I want to say that it's not a nice disease, and our earlier speaker spoke about this. Nobody needs this on their body. Agreed? I remember the last time I talked about cervical cancer, our governor, Cicely Barreira, I said it's bleeds. The women we see, there's a word now called, it used to be 6D, with my friend here and gynecologist. We all have clear memories of the acute gynae ward in Kenyatta. And I know all of you who worked in those wards, you have those memories. 3/4 of the women in that ward used to be women with late-stage cervical cancer. And we reached a point in the hospital where we had a policy of no admission because we're taking up all the blood. They come in bleeding, they're in pain, they're pouring pus, and if it's late-stage disease, it eats into the bladder, they're pouring urine, or it's eating to their backyard and they're pouring stools. So heaven's sake, colleagues, members, we can prevent this. This is a disease and a trauma that should not happen to any one of God's children. I think if we reach that agreement, we can currently agree that we should use the interventions that have been availed to us through science. Let me see if I can still move. Okay, it's stored on me again. Sorry. I know what I've done. Okay, Dr. Paul went through this. It's preventable. We know what causes it. We know all the tools. We can detect early, but our women are coming late stage. We talked about screening. So why haven't we done the screening and the secondary prevention? We have visual inspection, we were told. HPV is really expensive. But what I can tell you in Kenya, only about 16% of our women have been screened. 16%. Am I right? And out of the people screened who have a positive lesion, only 30% access treatment. And this treatment can be given by the nurse with a thermoablation, or we're told about the challenges of LEAP, which we keep seeing. So this is difficult. It's been there for years. We haven't been successful. And we're saying we need to use vaccination. So now I come to the vaccine. The vaccine uses a virus-like particle. I know safety has been a huge issue, and a lot of the misinformation is around safety. This is not a live vaccine. A lot of earlier vaccines were live and sort of mimic disease. This is a virus-like particle. I wanted to go here because I recently talked to some of my relatives about the vaccine, and I told them the work on the vaccine started way back in 1997. Because we do animal studies, safety studies, trials for efficacy, then scale-up studies and evaluation. In 2007, the FDA approved the vaccine. That's why we're being shown data by Dr. Paul about countries which now have evidence on cancer. But when did the vaccine come to us? In Kenya, we launched in 2019, right? Why was that? Because the vaccine was very expensive. And it's still expensive. So our vaccine is supported by Global Alliance for Vaccine Initiative. Unfortunately, it saddens me. I know last year we disposed of vaccines in Kenya which had expired, unused. And I think, yes, HPV vaccines, because of hesitancy at the community level. So people have created these fears. But I'm glad to know that we're increasing, right? So it's not a new vaccine. The WHO 1970-90 strategy was in 2018. So how many years later are we? No, from 2018. Yeah. Yeah. Yes. But the elimination strategy, yes. Yeah. So we are behind. And from 2007, we are further behind. Yeah? So we need to catch up. We started with iniquity of resources. We couldn't get the vaccine. When we got the vaccine, then we were challenged with other challenges. These were all the early studies. They're called proof of concept that were done to show that the vaccine is safe and it's effective. And you can see the efficacy rates are 98 and 100%. So this is a vaccine that works extremely well, is extremely safe. It prevents precancer. The 9-valent vaccine, which is not available, and the 2-valent. And the third group, which you see a lot more, got meningococcal, but now we vaccinated everybody because we know it works and it works well, and they continue showing protection. This data is from Scotland, and it's showing that huge reduction on a population level. And we heard from Paul Bloom again, in Scotland, they are showing no cases of cervical cancer on the girls who were vaccinated, who are now in their 30s, at the age of 12. So real-world data has shown these huge reductions in burden of disease in Sweden and the US. So it's real. We heard about Rwanda, which was an early starter, in Bhutan, and they've been able to show on population levels that they can prevent this. And they went ahead and vaccinated their girls in secondary school. So they had a bigger group, so they'll see the impact much earlier than the rest of us. And there's a lot of work on getting additional vaccines, yeah? So that hopefully that price will keep going down. So what is the goal on vaccination? We need to shrink the amount of HPV infection in our communities so we can shrink the amount of HPV disease and finally shrink the people with cancer. So with the vaccine, this is possible, and we can break that cycle. We can interrupt it. So I want to close by saying that the vaccines work. They work really well. I can tell you they're safe. In addition to that cohort for single dose, we've also done work on a group of adolescent girls and boys living with HIV, and we're on their 9-year follow-up. They've also had babies. So I want to also say that cervical cancer is a disease of inequity. Yeah? It's where resources are lacking, access to services. Women are not routinely screened, that women are dying from a disease that shouldn't happen. So we can change this. There's much to do, there's much to learn. And from Dr. Martin Luther King, of all forms of inequity, injustice in healthcare is the most shocking, and most of all, it's the most inhumane. And I understand why we have challenges in trusting science and government, not completely, but I know those are the challenges with this vaccine hesitancy, right? It's trust. Do we trust the science? Do we trust the government? And how do we break that? I think that's a challenge. So science has delivered the evidence. And it always humbles me to recognize this because I'm a healthcare worker, I'm a scientist, that when we deliver the evidence, we've only done a drop in the ocean. And at this point, the rest of the work is with the rest of us to make sure that this actually reaches the individual who needs it for it to have impact. That's all I have to say. Thank you.
Thank you very much. Professor, you are always proud about you and Professor Bukusi, the work that you do in Cambridge. We appreciate. And for women doctors in this country, we couldn't get one of our own to do that. We thank you very much for the resources. We remember the days of Professor Mushiri Lucy for the HPV vaccine was done here also with the Kenya Medical Women's Association. I thank you very much. I see some of my colleagues in the doctor. You can sit here. Yes. I see Dr. Wangai. Thank you very much. Benda, my favorite. I wouldn't have been here if it wasn't for Benda. So thank you very much. Before I take the last, Dr. Kapombe would like to go to the office because there's an urgency. I would like to ask the audience if there's somebody who has a burning question for her before we give her leave. Yes, I can see a hand at the corner. Dr. Kapombe, Dr. Sharon, if you're available. There are a few questions.
I'm here.
Yes, I will limit them, but I would like to give the audience to give you, I've seen one hand, second hand, and the third one. We could limit them from there. I will give myself from the steering desk. I will also give one, which I think is a pet that I wanted to ask. So please go ahead.
Can you sort of express what that means from the WHO perspective, the life course approach, thinking about young girls today who are going to be women and mothers and leaders of families later in life? How do we shift behaviors over time and think about that future, that the young girls today are going to be the future tomorrow? Perhaps you could talk about that a little bit. One other point, I think one thing that combines the science, the clinicians, community, and the faith community is working in the area of palliative care. And you mentioned palliative care, Sharon. I think it would be really important to talk about living with cervical cancer and the signs and symptoms that you live with, but also the opportunity of offering a good death, which I think this community here really knows something about.
Kindly, we will take the questions, all of them, so that she can address them if she can note them somewhere. Note the mic. I had directed the mic to the other, but because you're there, you can ask, then you can take the mic. Please, go ahead.
Thank you so much. Yes, I have a question for Dr. Paul, who joined virtually. He did acknowledge the power of civil society to build community trust. And I would want to know what WHO has put in place to ensure that civil society is empowered to actually build the community trust so that we can have the acceptance to HPV vaccine and screenings. And the second one I wanted to know, I think Dr. Paul, who is present here, did mention that single dose is even Professor Nelly did mention that single dose is as effective as 2 or 3 doses. And Dr. Paul laid an emphasis on the immunocompromised.
I will request that Dr. Paul takes that, but I'm only taking questions from Dr. Kapambo because
Okay.
he needs to leave. So just finish it, but you will keep it.
Yeah, how effective is the 3 doses for the HIV or immunocompromised girls?
Okay. The mic should move to the other side.
Thank you. I want to appreciate the presentation of Professor Nelly Mugo, the one I found speaking. And my concern is...
Can you direct to only Sharon Kapambo, which we want to release from the platform? So if it is from the other panelists, we still have a bit of time. we can negotiate about that. I only want for Sharon Kapambwe.
That's
our
what you
second
want.
speaker.
You want that, and we also want our questions raised.
No, we will do the questions, but I'm saying she needs to take leave. She's going for an agency.
Okay, fine then.
So if it's not for Sharon, kindly keep it. Dr. Sharon, before you take the questions that you have been given, you have been asked about the from womb to tomb. That is the slogan for Kenya Medical Women, looking at a girl from the, and I think that question has already been asked. But I want to look at it from the perspective of diagnostics and with the digital health and AI enabled. Is there anything that is going there? Is the science, is the continent being safeguarded? Are we being dumped? Because that is the area where I'm operating right now, and I can see a lot of either good things but also challenges, especially for women-specific AI-enabled devices. Is there something in the pipeline in terms of policy? Thank you. Hand it over to you. Thank you.
Thank you. So thank you, Julie. Julie, I think, asked me 2 questions and about the life course approach, where we are looking at a person's life and looking at their health needs in general as they go through life. What is it that, it's a big question, and I'm trying to see how best to break it up. So what we're looking is when a young girl, for example, if we map the life, we map from a time, we can just say from the time the woman is pregnant all the way, so until I die, what do I need in my life at a particular time? If I came as Sharon into the clinic, I tell you my age, and you know what are the things that we need to look for at this particular time in this person. That I am a candidate for cervical cancer, breast cancer, hypertension, high blood sugar, mental health, and you see me in a holistic approach as a person. The challenge with the life course that we keep seeing is our health systems are so siloed. They are more disease-specific than people-centered specific, and that's what we need to bring. From the young, when you look at cancer, it's going to have its own issues of social-cultural factors, the gender dynamics that are playing in the community, even at a very young age. And when we go even in the schools, when we are seeing these young girls, you find that maybe we tell the young girls, oh, you're going to get vaccinated, and the young boys are playing football somewhere. Already we are starting to create a disparity. Both of them should know about cervical cancer from that young age, because if the power dynamics are going to continue in life and they're not disrupted, and those boys don't know that this woman can get a risk, that's how we see women failing to come for services, because we found them with a lesion and we need to treat them, but they have to seek permission from their husband who sees it in another way. And partly so we need to start talking at a family level about health from a young age. I think prevention, what we have skewed our lives mostly is that hospitals, clinics are for treatment. I have to be sick for me to go into the clinic is a large part, and I hope that is something that will be covered much more in detail by this group. How do we break that? Because, when women are coming for screening, they're not feeling anything. They have no problems if they're coming for screening. They're symptomatic. They don't even know. Those cells which are abnormal on their cervix are not causing them any problem. And in bringing us up in a way where we see health facilities as places for people who are sick, then that already creates a problem. So children need to know that they can go and get attention even when they are not sick, because for non-communicable diseases in particular, and just like any other disease, is that when you are not sick is actually when we need you in the hospital, because then we know in the health facility that the intervention will be better. Putting the curriculum inclusive of issues of cervical cancer, some countries have already captured this in their sexual education that they do in schools, but also in the actual curriculum, is one of the ways that we try to make sure that as the children are growing up, this is something that is there. But it's also the people in the facilities. When we go to vaccinate, we just don't look out for cervical cancer. We look out at that girl. What does this girl need? She needs to be dewormed. She needs to know about menstrual hygiene. She needs, and until we start looking at people holistically, we'll be fighting battles in a siloed way. We finish with one, something else comes up, pops up, which we could have addressed in another way. So, Julie, I think life course involves us as a community, and there's also the health system that needs re-engineering to responding to people in a much holistic way. When we come to palliative care, palliative care is...
Dr. Kapumbe, I may request, because of the interest of time, that you will be brief there as one presentation.
Okay.
Yeah.
Thank you, sorry. So palliative care is something, I hope this group will break out to discuss palliative care as well. And Julie talked particularly about looking at death as part of palliative care. And we know that in our culture, we don't discuss death as much as we should. We know that this disease is terminal. There's faith to it. There's the traditional aspects of it. And those all, spiritual, should be part of palliative care. And someone dying in dignity is what palliative care looks out for. We shouldn't have women who are bleeding, literally bleeding to death. So we need to look at the symptoms that we can avert, the pain. Some of the countries that are present here, it's about legislation, into, for example, morphine being available at the community level. But most of all, it's us as Africans who are gathered here today, most of us, and those who are not, trying to unveil the issue of beginning to talk from a spiritual perspective, a medical perspective, an economical perspective, and preparing people in terminal life. How ready are we, and how should we? And I know Kenya has done some work on this, but I think, Julie, that's a Pandora box that needs to be opened, and we shouldn't let palliative care be shrouded in misuse. With WHO, we're looking at ensuring that indicators are captured, and we will be having a webinar on indicators for palliative care next week, which we've done in Benin, and then ensuring that legislation, all forms of legislation around palliative care, are there in the country. So from the cancer perspective and NCDs, we are looking at palliative care and ensuring that it starts being part of the treatment that we talk about for women.
I will have to cut you short, maybe.
Thank you. No, I'm actually finished.
Yeah.
Thank you so much. Thank you for the invitation. Thank you, Dr. Christine. Thank you, everyone. I'll try to see if I can rejoin later.
Okay.
But I'm 2 hours behind, so I started at 7:30. So I'll need to dash in the office, and thank you so much for the time.
Let me give you a parting shot. Thank you for you recently you got an award. You have several awards, but I'm sure Medical Women International, we were in Zambia. You got an award. Congratulations. I didn't attend as the outgoing regional vice president, but we acknowledge you, the work that you do in this space, and if you leave us kindly, join back again with your wealth of experience. We now want to thank you so sincerely for being here with us. Thank you very much.
Thank you so much.
Yeah. Applause for her before she leaves. Yeah. We would like to, I guess the time is over, and I want to engage Jane. Jane, we are thinking of giving you another slot in another session, if you don't mind, or you only have 5 minutes because I have to close this session by, yeah, if you can, which one is, I am a very inclusive person, democracy, which one would you want to take?
Certainly not the 5 minutes, thank you. So maybe you give me another slot. Yeah.
We will then communicate on email which slot we're taking, and we will give you that slot. Thank you very much.
Is that today, tomorrow, or when would that be, so that I plan myself?
I think it's today. You will communicate. Okay. Shortly at tea break, I'll communicate with you, don't worry. I'll get the slot.
Thank you.
Yeah. Yes, I would want to close this session, but before I do, I think I will do injustice. Allow me about 5 minutes to engage with a few of our audience, and our panelists would like to give their parting shots as well. I know there was a gentleman that had a question for Paul. Is that so? It had been asked, so he took it. Paul, you took the question? Yes, and there was a gentleman there, and he asked a question. Yes. I can see
I appreciate Professor Mugo's presentation.
Yes.
And I want to underline what she mentioned, that there is inequity in this treatment of cervical cancer. And I'm imagining coming from this continent of Africa, where sometimes we mention so many problems, but solutions are minimum because of our economic power. So I was concerned whether this cervical cancer can be either viewing or tested in our counties like here in Kenya or even other countries in Africa, because most of our hospitals are either level 5, level 4, and then maybe the referrals are level 6. So
allow me to get a precise question, because I'm seeing 2 hands and I want to close. The reason I'm not cutting you short, because...
But you are talking too much also.
No, I know there's something that is coming. Don't shout at the moderator. I have enough wisdom to see her this way. So if I tell you ask your question, please ask your question.
So please, also don't talk too much. So what I'm saying is this inequity, and you also know the levels of economic powers. So can somebody walk from a level 5 hospital and test this cervical cancer? That's one my concern. And the other one is also on the HPV vaccine that went into waste in some of our countries, possibly because of lack of knowledge. Maybe I want to start from the point of view of partnership, like this one, what Charles has done for us here, that we engage these religious leaders. Somebody mentioned that most of our countries are religious countries. So if they have voice in the communities, and we know they can engage their people in the forum of worship, possibly other than introducing a vaccine without the knowledge of the people, maybe why don't you start with the leaders who have a voice, so that at least we can advocate for this vaccine, so at least people, many more can at least have a chance of doing it. Good.
Thank you very much. I want to say a critical point. If you look at your program carefully, you will see that this session was to give an overview of the ground. And then those questions that we are now asking are coming into the next session, and they will be coming on the 3rd day. I am very clear that there will be a point for action, call for action, where the challenges would have been painted in the coming sessions, which we have not. This was to give you a snap overview of what is happening. Then you can deepen your understanding in the coming session. So if you find me that I'm cutting people short, don't think that I don't know what is going on. I am not rough, but I want to propel us to action. The lady, I'll give you.
It's a question for Dr. Kamfwa. I wanted to find out why the vaccine is only given to the young ones between 9 and 14 years and not extended to the women. Because waiting to get sick, that's when you go under treatment, I think is more expensive. If it is so expensive, why can't WHO come to our aid and help? Thank you.
Okay, I will take the last question of a gentleman at the back. Yes, and the panelists will give their parting shots.
Thank you very much. My question is directed to Professor Nelly. I believe that during the clinical trials, that is the time when we make sure the safety, the toxicity, and the efficacy is controlled. I wanted to ask whether during this period, there was a proper control arm used besides the intervention, because I've heard some doctors alleging that there was a metal in the control arm. So I'd want you to clarify that. And finally, after these clinical trials and the rolling on of the vaccines, do we have any monitoring to ensure that there are no serious adverse effects which can emerge during that time? Thank you.
Can the last lady take a very short, quick one?
Thank you so much. My name is Temptation. I'm working for WHO in Namibia, the country office. My question is actually out of excitement from what Dr. Paul from Zambia mentioned, that they've managed to kind of expand the scope of the NACE to include LEAP. If I got you right, I heard 9 nurses have been trained to do LEDs. Now, that is one very welcome, can I say, because in most of our countries we have got patients who are not treated, do not complete treatment because of shortage of doctors. My direct question is, so does this mean probably that this has gone through the Health Professions Council and the nurses are now permitted according to the scope, their scope to allow or include LEAP? Thank you and over.
Thank you very much. We will ask Mr. Bloom. There was a question on civil society. If you can, within about 30 seconds, address it. Then the panelists in the front will do their bit. Your parting shot, sir. He's gone. He left. Okay. If he did, I think we will address the issue of civil society. Some of us may be able to help there if he's already left. But could I kindly ask my panelists to address the issue and give their parting shots?
Maybe I'll start with LES or LEAP. If you look at, say, MD Anderson and these other world-class centers, LEAP is not just a preserve of medical doctors. It has gone to what we call LEAP nurses providers. And in fact, when you look at the 9 nurses that we have trained in Zambia, the training started somewhere in 2008. That's when we started. They were only certified about 4 years ago. And the certification was in collaboration with WHO, IFCPC, and IAC. So they had to undergo very extensive training, and they have been under the tutorage of national LEAP mentors. So these nurses, they don't just practice on their own. They are under the tutorage of that. One of the tutors is Professor Mwana Hamuntu, who has seen to it that this cohort is ably trained. We have written to GNC. We are yet to receive a correspondence so that we can then go to these other nurses, and this is what we are waiting, apart from those 9 key ones that have been trained. And by the way, they have been doing massive work, which is comparable to the general doctors, even gynecologists, those 9 nurses. Very fantastic work. Then let me quickly go to the one that the priest asked, but I believe it will be tackled again in the next phase, because remember the next panel will be now talking about vaccination. So please, when it comes to the efficacy the effectiveness, even when you talked about the side effects, the clinical trials, all these are going to be tackled in the next session. Don't worry, because what we were giving here, it was just an overview, but we shall take a deep dive into that. Now, a quick one. When you look at the first dose, or a single dose versus 2 doses, normally what happens in medicine is these undergo a clinical trial. And what they were looking at was immunogenicity. What we mean by immunogenicity is the immune response.
Doc, I will cut you short and pass over to them.
Thank you so much. So one dose is not as inferior to a 2 dose. It's same. We shall talk about this later. Let me allow my colleague, because there are even important things to mention before we close.
Okay, thank you. I'm going to be very brief in my responses. As you've said, this will be addressed. The issue of extension to the older cohort, I think it's about resources. We don't buy our own vaccines. So there's a limitation, and I think you've said it will be addressed. So the Global Alliance of Vaccine Initiative, they purchase our vaccines, UNICEF ships them, and we do the distribution of vaccines. The same issue of community engagement, it's again resources. When we do our resource allocation for vaccine launch and dissemination, is there resources, money allocated for continuous engagement and communication like this? And I know there was a budget for this and it wasn't cheap. But it can't be ignored because there's a cost to it. The one that came up on safety and adverse events, thank you so much for that question, because these are the issues that have been a barrier and have caused the misinformation. As a clinical trialist, I'm a clinical trialist, I want to confirm, even as we go to the next session, about the rigors of research. That there's absolutely no way. When we write a protocol, we don't determine whether we can do the protocol. It goes through a regulator to approve the protocol. And in the process of implementation, we get monitored by an independent agency again. And by the time, for example, agencies like EVA or FDA approve products, we've had their people come to our sites, go through our laboratory records, our clinical records, to confirm that the things that we said were true. Then they take our data again and they reanalyze it to evaluate if what we said were the results were actually the results. And I think later on we'll talk about the phase 1, phase 2, phase 3, phase 4, and the strategies that are in place. Remember I said this study started in 1997. Products were approved in 2007. So there's a lot of rigor in research. Because of the interest of time, I won't go into those details. I asked to speak and I really wanted to use this session to appreciate a colleague, a warrior for women who has fallen, and that's Professor Lynn Denny from Grootsky, South Africa. I trained with her. She's been a strong advocate. She's done clinical trials, the early trials on HPV vaccine. She's been a teacher, a professor, and a serious advocate for access to services.
Hi, Father Charles.
And I just wanted...
I'm good. I'm just waiting.
I just wanted to take a moment to appreciate her work because she died yesterday.
Yeah, I'm here. Yeah? Hello? Yeah?
Yesterday.
She died yesterday, and she also died from complications of breast cancer. So please join me as we mourn her passing and appreciate the work that she's done and contributed to this field. Thank you.
Thank you. I hope in some moment we'll get a 1-minute stand in memory of her when we get time, at the appropriate time. It is my singular pleasure to have been your moderator. In the spirit of where we are in where religion and science meet. If there's anybody that I have aggrieved, could you find it in your heart to forgive me? I'm a mortal human, I'm a human being who makes mistakes, but I had, for the interest of my time and the job that I was given to deliver, I had to do that. I'm sorry. And if somebody has not felt very happy, forgive me, and I forgive you also, so that we can move together. So thank you very much for having allowed me to say at this session, and I appreciate very much. So thank you very much, yes.
Amazing, splendid job from our panelists. A round of applause again as they said. Thank you. Our moderator, Dr. Christine. Now, I wouldn't want to take a lot of time. We are going for a short break now because we are pressed for time. 25 minutes, okay? So we'll be back at around 12 from our 12, please, all right? Let's keep time. You're at liberty to take a working tea in case 12 is here and you're not here, okay? All right, so thank you very much. Tea is right outside. I look forward to seeing you in our next session. Thank you.
allow questions so that we can engage to address any concerns and any feedback that we get from the crowd. So allow me to also introduce my panel. On the far end is Professor Themba Gininza. He's an epidemiologist with the University of KwaZulu-Natal. He's also a director of a research unit that's called SIDERU. He's done extensive work in lung cancer and cervical cancer, and currently running a vaccine trial that's multi-country. And we are happy to have him on the panel. Next to him is Dr. Tibera Rugambwa. She's a clinical oncologist working in southern Tanzania, and we are happy to have her with her. We have Ms. Theo Soa. She's a CEO of Gracia Michel Trust. She's done extensive work in women's rights initiatives, and we are happy to have her with us, also contribute to this discussion. Next to me, we have Ms. Benda Kithaka. Benda is the CEO of Kilele Trust, and great work that we've had, not just from her, but one of the survivors that actually shared her work here. We actually felt her work through the audience. Virtually, we have Rob Symes. Rob Symes is a CEO of an AI company called Fortel. Basically, Fortel does data collection and analysis using AI tools. And he will also be sharing his perspective from a just concluded multi-country data collection exercise on HPV vaccine uptake. So that's my panel, and I want to invite you to give a round of applause to our panelists. As we start, I would like to invite Professor Themba to basically paint the picture for us in terms of what the current landscape in terms of HPV vaccine uptake and the scourge of cervical cancer in Africa is.
Good afternoon. I think I'm too tall to stay. Can I be allowed to be able to listen only once? Sorry for the custom, but I will be allowed to stay here just for my 5-10 minutes.
5 minutes, thank you.
Thank you so much. As Jesse said, my name is KwaZulu-Natal, but my original home is the Kingdom of Eswatini. That's where I grew up and raised, and I understand the culture.
The sound team, please.
Thank you so much. I just want to touch base on the cancer from a general perspective. We have been talking about cervical cancer, but I think it's a hard time to understand the burden of cancer overall. That we are faced by the globe, which is cancer. And most of our priorities of our governments, they are focusing mainly on infectious diseases. And we are sitting on a bomb in all cancers across the globe, especially among the 12 cancers, which is 9 of them are linked to how we live and how we do things, which is your diet, your failure to be active, to do some exercise. Even now in our offices, we move on our chairs, we don't stand up. 500 meters away, we get into your Volvo, you drive to the shop. And there's so much that is linked to all those things. So if you look at 2022, over 20 million new cases has been recorded, cancer at a global level. 9.7 deaths occurred. And if you look at in terms of that, the trend is going to increase. To look in terms of that is going to increase in Africa. And all this increase is happening in Africa. Why Africa is so suffering? Is it because we have seen so much? No. It is because there is a lot of burden in terms of the infection. Most of the infections are actually leading to cancer. And also how we have diverted in terms of what we eat. We have moved our habits and eat other things that we're not supposed to do. And if you look at cancer, is the leading cause of deaths across the globe, cancer in general. So I just want to say there is a dynamic change which is happening now, because cancer is no more for the old people. It is also for the young. We are seeing the shift, the paradigm shift now. Quite a number of young people are actually dying or diagnosed of cancer in general. Why are we talking about this cancer? We have talked about cervical cancer a lot, but cervical cancer alone, it is not the only problem that is related to HPV, which is the vaccine that we want to talk about. There is head and neck, there is vulva, there is the vaginal cancer, there is anal cancer, there is penile cancer. These are cancers that are actually coming up, they're shooting up. If you look at the head and neck, it says soon it's going to surpass cervical cancer. And it will be history to talk about cervical cancer. And if we talk about the vaccine, that means the vaccine is going to prevent quite a number of those cancers. But if in Africa we're not doing so, then it means we will be heading for a disaster when cervical cancer is a history, but the head and neck cancers are going to be a problem. If you look at the US, these cancers are actually surpassing cervical cancer already. That's the challenge we're facing. And why are we not seeing that in Africa? The reason because it is not a priority in African countries. We are only concentrating on cervical cancer, and that's it. In some cases, we even misdiagnose cervical cancer with perennial cancers. And we think, this is still cervical cancer. But it is not cervical cancer. So that's a challenge we are facing. What exactly causes this cancer? We have said it's HPV. Is it all the HPV? All the 150 genotypes? No. There are about 14 high-risk cancers associated genotypes that actually lead to cervical cancer, lead to all the HPV-related cancers. And we have got other conditions, which recently we have noticed where I work, a high increase of a disease called papillomatosis that is increasing, which is just happening here over the head and neck from young population. And that is where we are heading. We're heading in terms of, it's a sign to say, these cancers are coming. I don't want to bore you. Let us talk about the issue in terms of our cervical cancer. If you look at HPV across Africa, the range of HPV prevalence, it ranges between 8.5 to 74%. 8.5, 74%. That means 7 people into 10 people have got what? HPV infection. That's a serious case. So let's talk about cervical cancer. Cervical cancer is a big problem, a crisis impacting in our women. However, I love the statement that the previous speaker said, it does not actually impact on only female alone. When you lose your wife, you have a frustration. And the kids also have issues. I have seen cervical cancer actually causing a problem to families. Divorce, neglected, the African context, our men are so weak. They are cowards. When the woman is diagnosed of cervical cancer, they run away. But when it's diagnosed of prostate cancer, the woman is always available. How pathetic we are as men. We fail to support. We are where we are because our men are failing us. We fail to support our women. Cervical cancer is killing our women, not because we don't have the power to do so, but because we run away from our responsibility as men. And the burden of HPV is high among who? Among men. And we are the most transmitter for the HPV. I know it's painful for the men now. They are saying, who's this guy telling us all these stories? But that's the truth. So when we are talking about this cervical cancer, 90% of them is sitting in our sub-African countries. And these rates are actually, when we talk about this, you must understand when you talk about burden. We are talking about the mortality, which is the death. We are talking about the incidence, which is new cases, the prevalence, which are the cases that are already existing. There's one component that none of you who presented here have talked about, which is the cost. How much does it cost the government to manage HPV-related cancers, especially cervical cancer? It's one of the problems that we are facing in our time. So we haven't talked about that one. I like what our doctor here said. Every 2 minutes, a woman is gone from cervical cancer. Every 2 minutes. So you can count how many women that are actually we are losing in terms of that. So let me touch something that is going to be, if you look at women that are living with HIV and AIDS, 6 times the cervical cancer presence among that individual. We, in sub-Saharan African countries, we have got a burden of HIV. And you can ask yourself, how much is cervical cancer in our region? It's a pity when you look at countries like Swaziland, we are talking about 84.5 per 100,000. Look at Malawi, 60-something per 100,000. Why? These are small countries. Remember the denominator versus the numerator. It also counts. West of it all, these are the countries that were hit by HIV. And HIV, I happened to do a projection study in 2018 when I was doing my PhD. Calculated that if you factor HIV into the model, it went up from 69 per 100,000 to 106 per 100,000. So that means whatever you are seeing that is being presented at 84 in Eswatini, it's excluding HIV. So in all the countries that are looking at the prevalence that is estimated, it's actually excluding HIV. If you put HIV, the burden is huge. And in most cases, the HIV positive women, they hardly survive because of their immune system that being compromised. And remember HIV, when these ARVs are given, we are gaining more and more of the aging population. When we are talking about aging population, we are not talking about very old people. We are saying, in other words, people that are HIV positive or living with HIV, they now have more years to live as compared to the previous years. So they live as anyone else, that is, as other negative women. But if you look in terms of that, it shows that cervical cancer among that population is severe. It's very amazing how much people are scared of Ebola. Yet, if you look at the statistic, the odds of dying from cervical cancer, it says the same as dying from Ebola. If you read the statistics, they will tell you when you talk about women. So let's talk about the cost so that I close. Most of our countries in Africa, we don't talk much about cost. Who is carrying the burden of that cost? It's the government, because most of our treatment are given by the government. When you look at other countries, the patient is paying only $1, up to $2. What happens to the 99% of that cost? It comes back to what? To the government. When you talk about costs, there is what you call prevalence model and incidence model when you are doing costing. Prevalence model, it means you are only looking at the existing structure in terms of the existing number that you have, which is the old cases that you have. But when you look at the incidence, you are looking at only the new cases. The politicians that we are coming from, they are not interested on what? Incidence. They're interested in numbers. How many people are there that they need my money? And now it's their money. It is our money. So beyond that, it's also what you call a service provider perspective. We cost based on what the government is costing the government alone. We are not taking in consideration the patient, the relatives. Then you look at societary cost perspective. Now you are including everybody. I happened to do a study in Eswatini, which was never done before. If you look at the other countries, in most of our countries, there is no cost studies that has been done on cervical cancer. Why? One of the biggest reasons, our countries are failing to utilize their health economics to come up with what we call a cost index, where you are going to cost everything at a market cost. Not just to give treatment and give treatment, you are not costing, how much is it costing you to manage one patient from screening to palliative until the patient gets out of the hospital. We don't do that. If you look at the Scandinavian countries, what they do, they've got all their own cost index. We don't have that cost index. Our health economics are sitting at WHO. They are not helping us anymore. They left our countries because we don't pay them. That's the biggest challenge. So what did we found? If you look at the Eswatini, the first study that was done in 2017, it was only societary cost. Swaziland alone, 16 million US dollars. Alone, just on cervical cancer. We look at a societary in 2021, it was 19 million, with a range between 16 to 24 million. Overall, global, we are talking about 1.5 billion US dollars for cervical cancer alone. So that means we are far from winning. As long as our budget in terms of our health sector is still very low, we are not going to win unless we take the initiative, one by one, change one person's life, take the initiative and say, I want to do something as far as cervical cancer is concerned. If you look at the HPV vaccination, I'm closing the coverage. The coverage in South Africa is actually sporadic. If you look at other countries, it's actually a no-go zone. It's very low. The only country that actually has done so well is Rwanda. Eswatini, which started in 6 months, they were able to get to 70% within 6 months. Why? It's a small country. I can drive that country within one corner west to the east, north to south. It also the willingness of the government, how they are using the schools in terms of the vaccination. But the challenge that we are facing in our countries is the population dynamics. The tribal, the culture, the religion. Thank you, Father, that you brought us here, because I believe the religion is going to change. We're going to have a paradigm shift. When the religions speak, everyone tends to listen. Thank you.
Thank you very much, Professor Temba. I think we now are beginning to get the feel of how, the disease is affecting our continent. And thank you so much for painting that picture very clearly. I want to invite Dr. Tibera. She's a clinical oncologist, and I want her to share some insights on our health infrastructure as a continent. How are we equipped to be able to address the issues of cervical cancer?
I trained in China. In China right now, it's evening. So that's, yeah, but good afternoon once again. So I am here to share something about how our healthcare infrastructure is equipped to manage cervical cancer patients. I would say it's not equipped as much as we wish it would be, because if you look at the availability of the resources that we have, and if we look at Tanzania as a case study, and which I think is a picture in most of our African countries. Look at the number of, let me start with X-rays. A simple diagnostic tool as X-rays. How many do we have? In my center alone where I work at in the southern region of Tanzania, you know. We have like, 2 X-rays. If we look at the number of ultrasounds, if you look at the number of CT scans, if you look at the number of MRIs, those are advanced. And that is to cater for, you know, all the medical conditions, not only cervical cancer. So there is a challenge when it comes to infrastructure. We are not that much equipped, and we are all witnesses to that. And this issue of equipment affects even the access to services. Because when people come for services, we don't have what it takes to cater for them, to care for them, we as clinicians. And for me, I'm a clinician, I'm a clinical oncologist. So it hurts, it really hurts. You don't have your radiotherapy. Radiotherapy is not working, it's broken down. Your chemotherapy drugs are not that available, are not that accessible. The cost, you know, all those things, they affect access to care. So when it comes to infrastructure, we still have a long way to go. Again, you know, when it comes to decision making, and if we use the model, the 3 delay model that is used in accessing maternal care, you know, who makes the decision? Because the first delay begins with deciding to go for treatment. As I am sick, but then I need the resources to go for treatment. Who gives me those resources? Is it my husband? Am I paying for myself? Is it my parents? And so on and so forth. Again, when you come to, okay, I've medicine, I'm going to the hospital. How am I going to the hospital? No roads. Now with the flooding, it makes things even worse. And then, so it's multifactorial. Okay, I've managed to reach the hospital. Me as the clinician who is attending this person, the index of suspicion, how high it is. Because when it comes to I have witnessed, you know, the patients that I take care of, who have been blessed enough to take care of, they come late not because they did not seek care early. It's because we as clinicians, we have failed them. We have the low index of suspicion. So a woman comes to me, you know, by the time she reaches to me, she has been to a clinical officer, she has been to, I don't know, she has been to a traditional healer, she has been to, you know, all that path. And then, okay, when she comes to me as a medical personnel, I tell her she has UTI. UTI is urinary tract infection. Or I don't know, she has, if it's gastric cancer, or you have peptic ulcers. If it's, you know, so on and so forth. We have low index of suspicion. And so at one point in time, we as clinicians, we have failed our people. And we have to be answerable to that. So again, when it comes to infrastructure, how is the training? How are we involving the low cadre practitioners who are the first point of contact of our people before they come to me at a referral hospital? Because by the time they come, they've passed through all this, and no one like thought that this could be cervical cancer. So we still have a long way to go. And I'm sharing this to provoke, you know, a discussion, to provoke, you know, our thoughts, to finding ways to improve our diagnosis, to find ways of improving our treatment, because even if you have the most sophisticated, you know, even if the services are available, but can our people access them? Professor Tema talked about cost, you know, and cost transforms to access. Can we afford these services? Do we reach on time? How high is the index of suspicion? So I wanted us to, because we have talked much about screening, that one is already covered. And also, again, when it comes to screening, I was also fortunate enough to participate in some of the community outreach programs. And in these programs, our women or our people, they are willing, so much willing, to come for screening, to come for treatment. In one of the programs that I participated, we would start at 9 a.m. and finish 12 midnight. People are still there. They are waiting for services. So it's not about, people just don't want to come. They are there, so long as we are that much willing to be there for them, to walk this journey with them. So, I mean, this thing is a little bit passionate to me, so but those are some of the things that I wanted us to, to discuss and think about at a broader scale, and find ways on how can we improve our access to care, how can we improve our infrastructure to help our people. Thank you so much.
Thank you so much, Dr. Tibera. You can feel the passion in her voice as a clinician, how she sees the patient and the problem through her eyes. And that is the state of our infrastructure as a continent. And I'm sure many of us in Zambia, Malawi, South Africa, even Kenya, we can relate to just, what she says. Thank you so much. I want to invite Rob Symes. If Rob, you're online, I want us to shift a little bit to HPV vaccination. You could share with us, just a summary of, the assessment that you just completed. It was a multi-country assessment that you just finished on HPV vaccination in Kenya, Uganda, and Zambia. So kindly, if you're able to take us through that very quickly in 3 minutes.
Of course, Jesse. Can you hear me, just to check?
We can.
Okay, fantastic. Well, it's great to be here. Jesse, thank you, and it's great to have the passion that's on this panel. And also thank you for Father Charles for inviting me to speak briefly. As Jesse said, we did a multi-country study across Kenya, Uganda, and Zambia on the topic of HPV vaccination. So I thought what I'd do is I'd just talk you through some of the key findings, and then we have published the document, we've given it to Father Charles, and I'm sure it will be made available to you if you're interested. We interviewed 5 different groups. So we interviewed school teachers, we interviewed parents, we interviewed faith leaders, and we interviewed healthcare professionals, as well as some people in government as well. We did this through a combination of outreach through the Catholic Sisters and using some technology, avatar technology, to collect the data. But the key findings really were quite stark. So the truth is that, as many of you will know, and it sounds probably quite obvious, but knowledge varies massively on HPV vaccinations, with healthcare workers obviously knowing the most, but many members of the community having limited knowledge. There's significant misinformation about the vaccine's safety and efficacy, as well as the side effects that are prevalent in many communities. And we had a number of quotes, not just in Zambia or Uganda, in Kenya as well, about the potential for a vaccine to stop someone's fertility. Now, the key thing in getting more vaccination uptake seemed to be healthcare professionals, religious leaders, and other community leaders to play a key role in explaining why the vaccine is important. One key finding actually was unusual. We were quite surprised about it, but while we spoke to some great faith leaders, and they were very keen on getting the vaccination to young girls, they were also the group that were most likely to refuse to participate in an interview. And I think that was probably because they said, and they told us, that they lacked the knowledge on the subject, and also that in some of the religious institutions they were part of, there was a lack of clear guidance. So it's something just to know, and I think it's not in every denomination, but it was transparent across some. There's clearly some financial constraints that limit vaccination uptake. It's not just about money per se. It's about transport. It's about mobilization. It's about training. And the biggest thing that came across all 3 countries was that good communication through the community and the media will almost certainly always lead to a spike in vaccination uptake. I'll just read you a few of the quotes from a few of the different providers. So there were some healthcare providers who essentially said, we often recommend patients who are eligible to get the HPV vaccination as a way of preventing later stage cancers. School teachers, the best ones, were integrating it into other topics, so especially in class, especially around their adolescence and reproductive health. So the best school teachers are integrating it into the classroom. Whereas parents, there was a much more mixed level of knowledge. So one of the parents told us in Zambia, the knowledge of HPV vaccinations is very low because people are not well informed, and there are many, many biases about it. And other parents in Uganda told us that people outside here, they don't have education, so very few of them are not educated in it. One of the religious leaders, which I found relatively surprising, told us that in religious life, we think this HPV vaccination can cause harm to the community and potentially deal with infertility. There were many religious leaders who didn't say that, who were very pro the vaccine as well. But it just shows you the differences of opinion that may be stopping this HPV vaccination rollout. And then the last one, which I thought was an interesting one, which was a government official in Zambia, said, I think the understanding of HPV vaccination on professionals is medium because they have radios and they listen to health talks organized by the Ministry of Health. While that's true, media plays a massive role, it's not the only thing. I think the best recommendations are going to come from local communities. Now, just briefly, the misconceptions really can be put into sort of two main buckets. So the first is infertility and family planning. So there are misconceptions around family planning hormones that will prevent children giving birth. I know one of the speakers earlier mentioned that clearly this isn't the case given the rates of pregnancy, and also there's potential for illness. But all of this means, all of these misconceptions and myths, it doesn't just mean that people won't take the vaccination, it means that they may delay in taking the vaccination. And that comes across a lot. This is a quote here. I'm waiting to make my decision because of such myths, but I need some counseling, more counseling, so I can make a good decision for my daughter. And this is where I suppose we need to have very strong indications of parents and school teachers and everyone in the community being very well informed. There's not one silver bullet with this, but there is a very important lesson to be learned. Now, the key people within this debate are healthcare providers, community leaders, and religious leaders. Healthcare professionals clearly have of authority within this area, but the other two play a big part of it as well. And then we asked people how we thought we could get the message out there, and they talked mainly, actually, most talked about better collaboration with schools. While spending money with the media was very important, better collaboration with schools was probably the most important of all findings. And the last one that I thought maybe just worth mentioning was the ability to work in local languages. So a lot of some of the perceived negativity is that the communication around this vaccination may not be done in the local language that the girls or the school teachers speak on a regular basis. And that seems to be a very important thing to change in the future. And just lastly, as I said, the barriers are many, but they are clearly money related. But money really means transport, it means fuel, and it means limited availability to fund and facilitate discussions. So this idea where, we may all think that it's an obvious thing that to roll out an HPV vaccination program, but actually we need to set up the infrastructure so that people are able to travel, they're able to receive training, and they're able to understand the importance of doing that. So on that note, I'll hand back to Jesse. As I said, we interviewed 383 people across 3 countries. We have many more findings and a series of recommendations as well that we've documented. So for those who are interested in it, I'm sure we can provide that later.
Thank you very much, Rob, for sharing that. I think we have a rich overview on just the perceptions of communities across these 3 countries in terms of just how they view the vaccination process. I'm conscious of time, and I want us to give the crowd just to respond to a few questions, but as we do that, just before we do that, I want to invite Theo to basically elaborate a little bit more and build on what Rob just shared about some of the socio-cultural barriers, economic barriers, and the role of myths and misinformation in delaying not only screening, but also the vaccination.
So as we've been sitting here, he's been telling me my time's getting smaller and smaller. So I'm going to be very quick, but I hope you'll ask questions afterwards. What I really wanted to emphasize from the things that have been said earlier, as well as some of the information that Rob just gave, is around two main pillars. One, actually going back to what I think it was Dr. Nelly who began with it, saying that this is a disease of inequity, of inequality and inequity. And I wanted to remind us that this issue of inequality and inequality breaking down our communities and preventing our countries from reaching our full potential is not only limited to cervical cancer. And so when we're looking at how we approach our response to cervical cancer, I think we need to make sure that we look more broadly. And that means going back to some of the things that were said earlier about even in the work that we do, whether it's in clinics, whether it's in schools, whether it's in our communities, making sure that even while we have a focus on cervical cancer, we are integrating our approaches more widely. So that, because women, girls, boys, we're all human beings. We are not one symptom. So if we say we're going to go in and deal with cervical cancer on its own, and not deal with other types of cancers, and not deal with HIV, and not deal with their general health, and not deal with girls knowing about their bodies and how they look after themselves, and later on how they look after their families, then we will fail. So I really want us to look at our approaches being integrated. I also wanted to add, Rob actually mentioned some of the issues around information and misinformation. Again, disinformation in our communities is not only limited to cervical cancer. I think that we actually are looking at a crisis of trust in our communities. People don't know what information to trust and what information not to trust. And while I believe the media is very important, the media can also be a very big provider of misinformation. And that's one of the areas where having religious communities, and I'm so happy to have the Jesuit communities linking with Islamic communities, linking with other faiths to address these issues. Because as a whole on our continent, we're a very spiritual people. And so in terms of who we trust, and therefore how, having religious communities well informed about these issues and prepared to bridge science, culture, and community is one of the strongest ways in which we can respond. But it goes back to the issue of being well informed. If our religious leaders are not well informed, they can be just as culpable of misinformation as anyone else. If our families are not well informed, they will hesitate before they act, because we are talking about children who are some of our biggest assets on our continent. You cannot expect a mother to say, we really need to look at how we speak to our communities, how we inform our families. And one of the biggest issues is also, how does science, how do the medics inform themselves about our communities? Because if we sit and we talk down to our communities, they will not respond well. If science doesn't listen to the survivors of cervical cancer, they will not know what the real issues are that hold people back from actually living with cervical cancer, but also eliminating it. And I know you want me to stop, so I will just say that one of the big motivations as we move forward really needs to be how we work together to overcome this. Someone already said that there is no silver bullet. We need a complete, holistic, integrated approach. But what we need to also know is that we should have hope about this. There are so many things that we do not know how to change. There are so many illnesses and diseases of all kinds that are holding our continent and the world back, and we don't know what to do about them. With cervical cancer, we do. We actually have the prevention, the screening, the treatment. We can eliminate this. And it's almost a failure of our moral duty if, knowing what we can do to change this, we do nothing about it. And so I would really encourage us to go forward in doing that. And then my final point is just about cost. Cost, there's the issues that were raised about things like costing community learning, costing how schools respond, costing for treatment, for transport. But there's also something about costing for the vaccine and for the treatment, the screening and the radiotherapy, etc. With vaccines, we've learned that by working together and by having people or entities like Gavi bargain for a collective buying of vaccinations, we can cut the cost. But we need to push them further because there are a lot of companies making a lot of money out of this work. And we need to make sure that as a continent, we do not suffer because other people put us further down the list for supply. One of the worst things I heard this year was about the fact that there was an insufficient supply of the HPV vaccine as a result of production issues. And I wanted to just say it's not just a result of production issues because someone made the decision to prioritize certain countries who may pay more and make a bigger profit as a result of that. And we need to be advocating as well for costs to go down so that our governments can afford to properly supply the vaccine, ultimately not just for girls and young women, but for boys, to make sure that we really have elimination.
Excellent, excellent, excellent points there. Thank you so much, Theo. I think this story will be incomplete without hearing from the field, hearing from the communities themselves. And I want to invite Benda to share with us about some of what we have seen or what has been documented as effective strategies in engaging communities, any innovations, any collaborations and partnerships that could facilitate the goals that we are pursuing in this discussion. Karibu. And you have, I told you.
Okay, so full disclosure, he's threatened me with 1 minute. And anybody who has ever given me a mic knows that I love to talk. So because of that, Jesse, I was tempted to stand over there and talk so that you can't come close to me. But in honor of the team that we're speaking to today, I'm going to sit and have this conversation around insights from the community. And I'm pretty sure you're asking yourself, why would I be speaking on behalf of the community? The reason is 13 years ago when I came into this field, I had no knowledge of cervical cancer. I had little interest in cervical cancer. In fact, the only pap smear I had ever done in 2003, I never went back for the results. Why? Because at that time, it didn't matter to me. I thought to myself, hey, it's a test, right? If they find anything, they will call me, and therefore they will tell me what's wrong with me. I was wrong. Because the call I got was about my sister, and she was told she had cancer. It was not cancer, it was pre-cancer of the cervix. I'm seated in an office, I have no interest. The only thing that I've ever had is cancer kills, and then the only thing I hear in that conversation, I did not hear pre-cancer, I did not hear anything else. I had cancer and I knew my sister was dying. Suffice it to say, God is good. 13 years later, my sister is well. It was pre-cancer of the cervix. It was found so early. She recovered, she went on to have a baby. Now I can see I have your attention. So let me tell you what has worked in the 13 years. We have worked in the community, and I sit here representing a community not just in Kenya, but across Africa, called the African Cervical Health Alliance. Organizations that are founded by survivors, caregivers, people in the community who have seen it, like I did, and have said, enough, we need to do something now. And when they start working with literally nothing. Not the information, not the time, not the expertise, not the knowledge, but the passion and the knowledge that they can do something for that one woman, for that one girl. These organizations are run on zero budgets. Yes, on zero budgets. So when we talk about costs, it should also be costed what civil society spends in creating awareness and education for communities to be able to take up prevention, okay? But the bigger thing that I've seen work in these civil society organizations is partnership. Because with partnerships, there are a number of things that we often imagine. When we say partnerships, we're thinking multinationals, and we are thinking big monies, and we are thinking many people coming with technical expertise. But partnership here is starting with ourselves, partnering with communities in our own households. You know, the family unit is the smallest community. Starting with that partnership to understand, when Professor Temba speaks about male involvement, it's that man in the household being committed enough, being motivated enough to want to talk to his wife about cervical health, and being able to take her, even by hand, to get screened. Being invested enough to be able to say, my daughters will be vaccinated. That is partnership, starting at the community level. And so with partnership, when I speak into it, the other insight that I found is now with community involvement, not just partnership at the familial level, but also communities taking up and saying, what's my space of influence? Today we are in a room filled with religious leaders from across Africa. By the way, Father Charlie, thank you. Because within this community that is here, we also have communities of civil society organizations from across Africa. One of the things I would pray is that when we leave these rooms, by the end of Thursday, we've also formed partnerships that can take this message back to our people. We'll be told about all the science, but if we don't break it down to the community well enough, it will not work. However, and this speaks into what Theo has spoken into, awareness and education. It really works. People fear that which they don't understand. Most often when you hear disinformation, misinformation, it's somebody who has had something, is passing it on, because even they themselves probably don't understand. Had you asked me in 2003 about pap smears, I would have told you, they didn't call me back, therefore I'm fine. That is disinformation. But because I came to learn about my sister and I learned about it, and I've understood it, we are using our voices as civil society to take that knowledge to the lowest of the levels, to the person who needs to understand it the best. Now imagine each one of you who has a pulpit. Some of you speak to over 3,000 people in a day. The reason being, when you do Mass, and we are attending from virtually, that is a huge community. Can you imagine if you just said, I have learned about cervical cancer, I have heard it is preventable, I have listened to the science, I have read about it, and this is what I have to say. Let's help our girls prevent. I, Bender, need never raise my voice again. So Jesse, as you're about to cut my voice because I'm talking too much, you asked me for insights that have worked, and I'll now do rapid fire. I've mentioned about community education and awareness. I think this team holds the power to do it. I have talked about community involvement and partnership. I think where gaps exist, for example, in knowledge, this team can also take up to be able to partner with community organizations that have people with lived experience that already are doing this in the community to amplify the voice and bring that voice of reason on the table. The third one, the church owns majority of the healthcare provision facilities. I know in my country it's the truth. I don't know about other countries. And one of the things that I know is that is where you will get primary care in health, higher index of suspicion in health. That is where women will run to when the child has a cough. That's where the women will run to when a child has hurt their leg. That is where they will run to when there is malaria and everything else. And therefore, if we equip the primary healthcare facilities with knowledge and skills and expertise to spot it early, to get women to understand, don't wait for the signs and symptoms, to get girls to understand, ask your parents about the vaccine so that you come and get vaccinated. This will no longer be a dialogue that you need to have. It will be, we'll come back in a year to say, we did it. And lastly, Jesse, on male involvement, it hurts me deeply when I hear Professor Themba say our men have failed us. Because those are the realities that we face daily. Women being abandoned at their hour of need. But that's not where the men folk need to be involved at, not when the disease is already invasive. Yes, there is a need for that, and yes, we need to sensitize our men to stay, but we need our men to be the critical voices at the far end, at the very beginning, understanding the risk factors, understanding the role of men in health-defining behaviors. For example, in our African culture, we know majority of the people not in this room who are in the community, they actually seek permission to go get sick. Or the woman is so busy that she has to run the household, run the children, run everything, the cows and the chicken and the goats, that if she takes time out, there will be something failing in that household. So the man needs to be involved to stand in the gap at that moment for the woman to be able to go get screened. Or the man needs to stand in the gap to take the girls himself, go get them vaccinated. At that point of the starting, where the river is starting, is where we need the men. Men run countries. They run budgets in governments. Men run schools. Men run pulpits. We have priests, right? Male involvement is not just about at the tail end. It's at the beginning, the genesis. That is where we're going to beat cervical cancer. I pray you all join us. Thank you.
Thank you so much. Thank you so much, Benda, and my colleagues here. I want to invite two questions from the crowd, the audience. We have one hand here. The sound, please, and then Prof here. Let's start with those two, and then we'll come back to that. And then the lady with the hijab. Yes, please.
Very quickly, just 3 comments. Can I make 3 comments?
Please.
Comment number 1 is that thank you very much for all the presenters. You did really, really good. You captivated us. Now, one of the things that captivated me was this great argument that we must embrace now. It is the argument of cost of the vaccine. And actually, I did not think of this some time back. But it was the issue of cost of vaccine versus treatment of patients. This is a very compelling argument. Now, I put numbers to that. For example, if the cost of treating one case of cancer of the cervix is $4,000, if you divide that with the cost, the current cost, or the previous cost, which was $50, you see that you can vaccinate 100 women, young women, okay? Then I think Professor Temba escalated this. He gave us a number, $16 million used to treat per year in Swaziland, I think, or was it Eswatini? Now, that translates to 332,000 vaccines that can be delivered within that cost. So I think that Africans, we must also embrace numbers, okay, in our arguments. So let's also deal with numbers. The second comment was from UMAD 1, 2, 3. The third one, I'm sorry, I didn't get the name.
Dr. Tibera.
But in green, yeah, it was...
Theo, okay.
Yes, yes. It was a mistrust of vaccines. Now, we must also try to see who is bringing the mistrust. I've been thinking, is a mistrust coming from an African? Of course, Africans are generally mistrusting, Western medicine. But I don't think that we are the ones escalating this mistrust on social media. I think the origin is outside of Africa. Is the origin of this mistrust, is it religious? Have we ever heard our Catholics stand on a podium and say that vaccines are bad? I don't think so. Okay? I don't think so. Is the origin cultural? Well, I don't know. But I will say this, that the silence in countering mistrust is the problem. That's the problem. The third comment, I think, is from the last speaker who said that, and she emphasized that men have failed. Men have failed us. I don't think so. I think you need to wake up men. Men are cheating. Men are looking after themselves in cancer of the prostate. They are concerned more about cancer of the prostate. So it's not that they have failed, no. They've just abandoned their obligation to look after their partner. They are looking after themselves, all right? So let's get men outside of this selfishness of looking at themselves in cancer of the prostate. They have not failed.
Thank you so much. Thank you so much, Prof.
Hello, everyone.
Okay.
We're going to have a plenary session later in the afternoon.
So, I think Prof says, yeah? Okay.
Very, very short. Thank you so much. Sorry. I just wanted to really concur with Ben and the others and my colleague from Tanzania, and also challenge my colleagues in the church, because I have a running project trying to implement screening in health services. And because cancer of the cervix is not an indicator anywhere that people have to report on, then it just doesn't get taken up. So I may not be here on day 3, and my challenge is just to think through how to motivate the healthcare worker and how to make it a reportable indicator so that it actually gets done.
I just want us to wrap it up there. Okay.
Thank you. A brief one.
Yes, please.
Just to concur with the presenters on accessibility, and indeed the presentation that was very, very emotional on accessibility. We find that in most of the hospitals, patients may go there and it's about the know-who factor. It is my concern that maybe if we can lobby with the governments to have special cancer units where patients of different cancers can get assistance from. And also to counter the one that just spoke about men looking after themselves, but it's a fact. And what he has said just confirms what men are like. And the final thing is that when these women are abandoned and they lack accessibility in the hospitals, they opt for prayers. I don't know with my fellow countrymen, where women, they would opt for getting admitted in prayer rooms, where prophets would pray for them while their cases are deteriorating. Maybe we have to look into it to see that we have not mobilized a lot, and we have not sensitized the community enough, and we find our women opting for prayers where they go and stay there for a month or so, and in the process, making the whole thing worse. Thank you.
Thank you very much. Please appreciate yourselves as an audience for being engaged. Appreciate our panelists. Thank you so much. Over to you.
All right, thank you so much. You will agree with me that this has been a very exceptional session, right? And I know we are burning with all these things we want to say. We are in luck because in the afternoon, sometime in the afternoon, we will have an open plenary session, okay? So don't you worry. We will give you your 30 seconds and 1 minute to talk. So thank you so much. Round of applause as they go back to their seats. Now, it's lunchtime, okay? So we should be back by 2. Please, promise me, we will be seated by 2 because we are pressed for time. Yeah? All right, thank you very, very much. We'll be guided on where we'll have the lunch. Thank you. See you at 2 p.m. Please, we will get our meal vouchers at the door as we leave, okay? So either of the doors. Please. We'll have lunch at the restaurant. Where? At the restaurant, ground floor. Yeah, we'll be directed as we leave, okay? An emphasis that we should be back at 2. Please, come on, let's leave for lunch.
We don't even have to go to 2030. Yes, but Brenda was just talking about how priests talk to 3,000 people every Sunday. And now they can even reach more. Yeah. So now, to get us going, we have Dr. Mwakio and Sister Teresia, who are bioethicists and theologians. Maybe let me start with you, just 3 to 5 minutes, Doctor. Could you highlight for us what are the real issues? What are the key concerns of the church around vaccination? The church doesn't know say no to vaccination, or the other religious groups, but they have some concerns that need to be addressed. Could you highlight some of those, the key ones?
Thank you, Father. First of all, I would start by saying that the Church, especially the Catholic Church, has been seen in most cases as an opposer to the vaccines, be it the polio, be it the measles, be it some of them, even the COVID one, they were hesitant to take it, and the HPV one, among other. But as Father has exactly said, science and faith are not enemies. In fact, both science and faith seek the truth, and particularly the truth which is not known, which we are trying sometimes, we are trying actually to know the truth when we are screening for cancer. Some people don't want to even to meet that truth. We want to reach at that level of even knowing that truth. And not only that, to realize also that we have limits. Whether it is religion, whether it is science, we have limits. And to just pick up from where you left before I mentioned those other points, Pope John Paul II spoke to one of the Jesuits sometime back in Rome and told him that science can actually purify religion. From what? From error and from superstition. Which error? For instance, let's talk of the issue of Galilei, when you're saying the earth moves around the sun, and the church was saying, no, it's not possible. That was an error somehow, and it was corrected. It was true that the earth moves around the sun. Superstition, you have just mentioned, and science can purify religion from superstition. You are suffering from cancer, you're suffering from malaria, and you say it is because that old woman looked at me with one eye, that's why I'm sick. Or I'm possessed by the spirits, evil spirits. Science can purify that because it has evidence of what causes malaria, what causes cancer. So, which are some, and religion can purify science from idolatry and false absolutes. Okay, science can predict many things, can say many things, but it cannot play God. It cannot, let's say, be adored as the whole truth. That is something which the church comes in to guide science and even putting matters of ethics and so forth. So the church has concerns about HPV vaccines. The first and foremost is that of safety of the vaccine. This is a concern. The church, of course, advocates for the right to life, and anything which seems to threaten life is a concern. If the vaccines themselves, for instance, are not safe, that is a great concern to the church. And we rely on scientific evidence, we rely on all the other mechanisms to prove to us that this vaccine is safe. There have been cases in the past, definitely, whereby human beings have been used during research. We know the history very well, the Tuskegee and many other of those which gave rise to the Belmont report and other reports on how to treat human subjects and so forth. So the church has to be concerned about the safety, whether or even if these vaccines are just being brought here to Africa, there is that concern. We are used as guinea pigs. We were used as guinea pigs. Is there such a concern? So when that is clarified, the church has no issues with that vaccine. The other issue was about the gender issue. The main concern was why only girls and of a particular age, which is not very active age sexually. Of course, we are not denying that there are issues of changes of behavior whereby very young people are getting involved into sexual activities and others are being abused. The other challenge was about sexual morality impact. If people are made to believe that only and only maybe the HPV vaccine will save us from the cancer, what of the moral impact? Are they able to say, okay, now I'm free from this cancer because I have the vaccine? I can live the way I want because it is contacted sexually, whether it is not necessarily through intercourse, even contact. So those are some of the concerns which the church had. Thank you.
Thank you very much, Dr. Markio. And I think what you're trying to say is the church has concerns, but that doesn't mean that the church says so. It raises concerns which need to be resolved through dialogue between science and faith, and that's the way we need to go. But there are also cultural concerns around these things. Would you like, Princess, would you like to highlight some of the cultural concerns around vaccination that are rife in Africa, that inhibit or slow down the uptake of the vaccine? A couple of them.
First of all, thank you. It's not a big issue because we have an annual returns every year, which brings close to 10,000 young girls. So they pitch up tents, the health people, they pitch up tents for them to teach them about this vaccine. And for us in Eswatini, it just came, the vaccine just arrived last year in June. So, but right now, we are in 70% with the vaccine. So, which means the people are taking it into serious consideration. So it's not a problem, just that we don't have the rural areas, we can't reach them because we don't have we don't have cars and everything to take them to tell them about it. So that's why the youth, they usually go door to door in the rural areas. Otherwise, everything is going well because the parents, they do understand that this is a serious issue. Yes.
So the key issue there is communication, education,
yes,
and where there are barriers to address them.
Yes.
Yeah.
Yes.
Otherwise, many cultures, including yours, are open.
Yes, we are open to
vaccination as long as there's communication.
Eswatini is open to it. Yeah. Yes. We are trying to do campaigns to make them learn about it more. Yeah. Yes.
Imam Ivudo, all the way from West Africa. What would you highlight as some of the key concerns in the Islam religion? Not blocks like I say with the Christian faith, but some of the key concerns that need to be addressed before vaccination is given.
Father, you had to help me for traduction. Okay. Merci.
Thank you.
C'est vrai, l'islam et puis le christianisme sont voisins parce que nous procédons des mêmes écritures et nous partageons une grande partie de l'histoire.
There's a relationship between Christianity and Islam because we come from the same writings.
Et l'islam a presque la même histoire avec la science. Il y a eu des moments où il y a eu des grandes percées scientifiques. Et comme quand nous disons Avicenne en français, qui a été un grand médecin, c'est que c'est la latinisation du nom Abu Ali ibn Sina.
Islam also has actually the same history as science, and we find in science Islamic people who have come out as great thinkers, including a medical doctor.
Avicenne. Avicenne.
Yeah.
Abu Ali ibn Sina. Et généralement, la plupart des mots où nous avons le suffixe al, comme alcool, alambic, et beaucoup de mots qui sont liés peut-être à la médecine sont des mots d'origine arabe. Donc on peut dire que dans
you can see there are even words that used in science that have Arabic origin, like alcohol.
Ouais. Alcohol.
Alcohol.
Voilà. Alambic, pour dire alambic, le truc pour l'utilisation. Ouais. Bon, c'est pour dire que dans le passé, effectivement, il y avait cette relation très étroite, mais aujourd'hui, ce n'est plus le cas.
Yeah, and it is true that before there was a relation between science and Islam that was quite narrow, but now it's no longer the case.
On peut dire aussi que, comme je l'ai dit dans mon introduction, l'islam accorde une place très importante à la vie humaine et travaille pour la préserver.
And Islam, just like science, works for the protection of life, for the respect of life and the protection of life.
Donc tout ce qui va rentrer dans la prévention de la maladie par des comportements pour l'éviter, comme par exemple le fait de ne pas boire de l'alcool, d'éviter des substances interdites, et tout cela fait partie des dispositions pour éviter au corps de tomber malade.
For example, Islam has teachings that help human beings save themselves from diseases. For example, Islam speaks about the need to avoid alcohol abuse and other things. Even when you consider, in a way, HPV, there are ways that can help a human being by their behavior
L'islam va
to
enseigner.
reduce contact with disease.
L'islam va enseigner aussi des manières concernant la propriété, l'hygiène, pour éviter d'être malade et aussi de se soigner quand on tombe malade.
And recently we can speak of teachings about how young people can keep themselves pure, to avoid disease, but also how to respond when they encounter disease.
Mais actuellement, nous rencontrons dans notre sous-région ouest africaine et peut-être ailleurs aussi deux principales méfiances par rapport à des traitements et principalement à la vaccination.
There are particularly two forms of mistrust that come out of Islamic religion in West Africa that I would like to highlight.
Et la première, c'est le fait que certains prédicateurs font croire à la population que tout ce qui rentre dans la médication et surtout la vaccination vise surtout la plupart du temps à dépeupler, dépeupler l'Afrique, à stériliser les hommes, les femmes, à les rendre stériles pour diminuer la population africaine et la population musulmane.
There are real concerns that some of the contents of vaccines could be aimed at depopulating the Africans or the Muslim populations. Those are concerns, sources of mistrust.
La deuxième raison a été évoquée par le père ici, c'est que il y a aussi ceux qui pensent que ça va entraîner la démoralisation, la dépravation des mœurs au sein de la population parce que certaines vaccinations protègent contre certaines maladies, quand on pense au sida, quand on pense aux maladies sexuellement transmissibles, et que si les populations se croient protégées, ils vont se livrer à cette vie immorale.
Yeah, just like Father mentioned, there is a concern about the content, the quality of vaccines, and that needs to be addressed because there have been real situations where there's mistrust around what are the contents of those vaccines, and those are issues that need to be addressed.
Je prends en exemple la vaccination contre la COVID. Dans notre sous-région, sous réserve des médecins qui sont ici, mais dans la sous-région ouest-africaine et principalement sahélienne où il y a trop de soleil, nous n'avons pas senti le phénomène comme ailleurs. Ça fait que quand on a parlé de vaccination, de se protéger, et les gens ne croyaient pas, on se disait c'est un complot mondial, etc., pour affaiblir encore l'Afrique. J'ai eu la chance de...
Yeah, it's just giving another example like COVID. West Africa was not as affected as other parts of the world. So there's that thinking that some of these efforts to sort of affect Africans. But those are just concerns that arise from among populations.
Ok. J'ai eu la chance d'avoir des fonds de ACRL, Religion for Peace, d'ici, de Nairobi.
Mais vous pouvez souligner un concern à partir des religions, islam. Okay? Il y a des perceptions, hein, comme vous l'avez dit, mais il y a des concerns à partir de la religion. Il y en a
des conseils.
Les conseils.
Oui, c'est un peu cela.
Oh,
c'est même là. Donc, je termine par ça. Quand nous avons reçu des fonds pour la COVID, pour faire la vaccination, voilà, on a reçu de ACRL Nairobi ici. Nous avons mené ça avec le deuxième plus grand hôpital. Et ce jour, nous avons eu 30 personnes qui se sont vaccinées. Voilà. Donc, toute la campagne. Donc, et quand nous avons fermé les mosquées, les jeunes musulmans ont fait une marche sur la fêtière des religions musulmanes pour demander l'ouverture parce qu'ils ne croyaient pas. Donc, je vais dire que pour certains vaccins, voilà, surtout quand ça concerne les femmes, voilà, ces idées-là peuvent rester. Ça peut être pas seulement pour les musulmans, mais pour la population entière. Donc,
so
voilà ce que
there
je
are
peux
these
dire.
concerns that he has raised, and he's given an example here in Kenya, what happened and the laws that were passed to close, various places, including various places of worship, and young Muslims protested for the opening of their mosques. But he's just raising the concerns that arise even beyond the Muslim religion that are held by Africans that are quite serious and real. Some of them were mentioned this morning. Okay. And I think, tomorrow we will have a chance actually to have scientists, manufacturers of vaccines and government to explain to us how the development of vaccines happens, how they are adopted by governments and how they are distributed, and I think they can answer to those concerns.
Okay.
Sister Teresa, maybe you can begin to help us understand how does, when there are issues like these that are raised, concerns from the church, how we can go around them from a theological perspective, if you like. Is there room so that we don't block what can bring about life, but is there room in Christian theology that can help us, go around some of these concerns?
Yeah, thank you for having me here. And I want to affirm that the church is not opposed to vaccination. This is following from different documents from the church, like Pontifical Academy for Life. What the church is challenging is the whole issue of how the vaccines come about and the issues that we have raised. But I want to propose a way of how we can go about this. One, each and every person here has attested that the church is a very influential and a trusted ground. And so we would call upon the need for collaboration between faith-based communities, like the forum that we are having here, that we can be able to have that collaboration between the church and the other sciences. And then also there is a need, even when we are talking about vaccine, the church is so much advocating for integral human development. That we not only look at this person who is sick, trying to talk about prevention, but we look at the entire person. The integral development is what we would try to address this issue. And then there is a need for respect, especially to realize that science is based on evidence, while the church is also based on revelation. So there's a need to have that respect between the religion and science.
In other words, that the truth comes from what we see, but the truth does not only come from what you see, but from revelation. Can you do more about revelation? How can we arrive at the truth through revelation?
Yeah, we arrive at the truth through revelation, and according to the church, this truth or this revelation comes to us of course, through the sacred scriptures and through the church tradition. And especially like where we are talking about now, the whole issue of vaccine, it follows the ethics that even if this vaccine is developed, then ethics must be followed. So that's why we are talking about the tradition and the scriptures, they give us that aspect of the
For example,
the
when we highlight the dignity of the human person, science will not prove the dignity of the human person. But spiritual traditions, scriptures tell us that the human person is sacred. Is that correct?
Yeah, in fact, that was a point that I wanted to affirm. Even when we are talking about vaccination, we have to consider, of course, the principles of ethics, like beneficence, non-maleficence, and also especially the informed consent. Many of us here affirmed that there is no that, people don't lack the information. And then also the issue of being pro-life, to protect life. Someone has said that, there is that worry that this vaccine can lead to, to sterilization. So the church is also advocate for pro-life. Whatever means that we use, then we must have be guided by pro-life at the central.
Yeah. Thank you very much, sister. Ladies and gentlemen, we are here trying to see the relationship between faith and science. And what we are seeing, or what we are hearing here, is that there's no division, there's no disagreement. Both need each other, and both must respect each other, because both inform the other. Religion supports, or let me call it faith. Faith supports science, and science also supports faith. And like Father put it very eloquently there, that science purifies faith, and faith purifies science. This is important for us to advance this agenda. But other than the fact of reflection on these issues and the writing that we do and analysis, there's also the fact that there are real human beings in society. While you and I are analyzing, debating, it is also true that there are human beings, as the doctor put it, to every 2 minutes there's a woman dying. That's a fact. And the church is among these people. The church is not in the cathedral. The church is among these people. That's what the church is. Sister, you're a pastoral theologian, very practical theology. Could you highlight how the church is present to real concerns of people suffering? People are dying. Women are dying of HPV. Yeah. How is the church concerned about this from a pastoral perspective?
Thank you, Father.
Practical.
The church is very much concerned when we see what is happening today. And in fact, we have a methodology that we follow that helps us to meet people where they are. And this methodology invites us to ask ourselves what is happening. And as Father has said, people are dying. People are confused. People are in denial, in fact, because they are confused. They don't know what is next. And so the church is calling us to be there, to be with the people, to smell the smell of the sheep. And this is what Pope Francis is inviting us to go and smell. It's not the smell of the normal sheep that we have at home, but the smell of the sheep that is the human person, the person who is suffering, the person who is in denial, the person who is sick. In fact, when these people are sick, also the church is sick, and we are all sick. And so we need to be with the people so that we may remedy all that what they are experiencing by asking ourselves, what is happening? And that is why the church invites us again to ask ourselves, but why is it happening? And the church is inviting us to ask ourselves that question and base ourselves in two areas where we need also to look at the professional way. How are we going to gather information of why are these things happening today? Professional way in that we need to read. I should not say I heard, but I should bring facts that this is what is happening, it is affecting people, and these are the causes. But mostly we need to get the experiences. One of the theologians says, if you want to give a good answer You must begin from the experience of the human person. And this is now what the church is calling us, the experiential part of it. I go, I smell that smell of the sheep. I feel what people are feeling. And it is from there I'll be able to say, this is the way to go. This is the way, the route we need to take. And so without that, the knowledge we have, all the experiences that we have, will just remain incomplete and in fact broken, because they cannot help the people. And that is why people are sick. And so unless we go down to the grassroots and begin from there, smell that smell, even if it smells as bad as what, that is the only way we can go.
Thank you, sister. That's very, very powerful. What sister is saying, you know, there's need for analysis, but before you analyze, you have to be attentive to experience. Is that correct, sister? And that's what the church wants to do, to be attentive to experience, to be with people as they suffer. And that's very powerful, the way you put it, that when people, human beings, the church is sick. So what sister is saying, if the African population is suffering from HPV, sick from HPV, it's the body of Christ, it's the church that is sick. And the church is not opposed, sister is saying, to analysis. Why is this happening? That's when science kicks in. Why? When we ask the question, why? And so you see the polarity of that, the reason and the faith, from an analytical perspective. And we have a very good example from Rwanda. Sister Epiphany Umuvyei, you know, your country has vaccinated up to 98% of girls. And we had a discussion the other day, and you were saying that you are at the forefront working with government, with medical people, and you yourself are a nurse. You are a nurse, sister?
Yes, yes.
Yeah, so you have a mixture of the two. There's religion in you, there is science in you, and how you collaborated with other health professionals and the government to support vaccination. And you actually mentioned that at that time, most of the health institutions were Catholic-owned. Could you just maybe share with the Assembly how what we have been talking about theoretically, how it has worked for Rwanda in practice? Just from your own experience. Yeah.
Thank you very much for inviting us. It's a great pleasure for us to be here from Rwanda. And even from starting, I can agree that when faith and science work together, we can really find a solution for cervical cancer. According to our experience, first of all, I can also say that cervical cancer is also a significant public health issue in Rwanda, primarily caused by human papilloma virus. And this cancer ranks as the second most frequent cancer among women in Rwanda, and the first most frequent cancer among women between 15 and 44 years old. In response to that public health issue, Rwanda initiated a national HPV vaccination campaign, and it was in April 2011. That campaign was targeting, of course, young women in order to prevent them from having this cervical cancer late in their life. So I witnessed that campaign, and it began very well with a sensitive campaign, a sensitization campaign that involved numerous of all stakeholders, including a Catholic Church. And of course, as a Christian religious leader, I was there around, I participated in that sensitization. And myself, I took a part.
What is your conviction in doing that? Your scientific knowledge or your faith? Or both?
Both. I can say that I was very much challenged by, as a Christian, by this belief of a healthy spirit in a healthy body, inspired by St. Paul in the letter to the Corinthians. And then that scripture foundation helped me to bring it together, to bridge the gap between religious beliefs and also scientific advancement. That's why I can agree that when faith and science work together, like in Rwanda, they worked together until now they are still working together. So when that campaign began, I was a director of a medical center in Kigali. It's an own Catholic church hospital located in Kigali. And I can say that, the location, is with the people with a lot of, socio-economic issues, a high prevalence of HIV/AIDS, problem of prostitution, problem of poverty. You understand how my people were exposed to that, cervical cancer. Then I took part of that. And also according to the vision statement of my hospital, that is taken from St. John, the Gospel, chapter 10, verse 10, I have come so that they may have life and life to the full. Mm-hmm. You understand how much I was challenged. I was much influenced by that. So for myself, I considered myself as a God instrument of compassion and for mercy in order to protect those people. So for me, that vaccination was a kind of giving life to people, especially those people around me. Because, they have said it, almost all of them, that, even people from far, we only serve, as a religious, we don't only serve people from the catchment of area. People trust us. They come far, to seek our service because they trust in the quality of our services. So for me, I took it as a message, a mission to give life to those people. And what was the most important also was the involvement of the Catholic Church. It was very much seen in Rwanda because even though there was, misconception, from some community members, but because religious institutions, the government, and the civil society organization, they were together from before. I can say that there was an effective sensitization that involved everyone with the clear messages. So the Catholic Church helped us to, even to spread the message about that campaign, because even there were announcements about the campaign against
in the churches.
In the churches. Just
ladies and gentlemen, just to remind you, Rwanda at that time was 90-something% Catholic. Not that we are promoting the Catholic faith, but what Sister is saying is that they use that platform to reach masses.
Yes.
And the drive there, what has touched me, Sister, is compassion.
Yeah.
Because Sister and others saw the girls and now they are giving themselves to bad behavior, the poverty, and Sister and others use that platform to reach the girls, to support government effort to vaccinate. That's very, very powerful. Shall we applaud that, please? Thank you very much, Sister. And you have highlighted something very important, that even ourselves, science works, but there are things that come from our spirituality, like, compassion. You can't learn compassion from a science lab. No. You can't learn mercy. So what was driving Sister, even maybe working at midnight, was because there's compassion, there's a drive. And that's how faith and other resources contribute to human endeavor. Thank you very much. Let's just applaud them. They're good. Yeah. Maybe just to open up, great people, to the congregation, the assembly. You have highlighted a number of issues that may have stirred some thoughts in some of them. Anybody would like to make a comment or a question that the panel could comment on or respond to? Sister Lucy? My sister there? Brenda? So we take the first three. Sister Lucy.
But as religious, most of us work in health institutions. And I have not seen, I'm from Ghana anyway, I have not seen any clear guidance or guideline from the Catholic Bishops' Conference that, okay, go ahead and advocate for HPV vaccine. I know when the COVID was here, the Holy Father himself started very well, promoted the campaign to go, the religious go, and campaign for vaccination. But I have not seen anything in terms of HPV vaccination. If I go now to Ghana and I want to start, am I going to have conflict with the Bishops' Conference? Because the communities where we work, those are their pastoral jurisdiction. The schools where we are, or where we aim to vaccinate these children, belong to the Catholic Church, most of them, where we work, and the hospitals. So I would like us to clarify that issue, that we will not have any conflict when we go back to start campaigning for HPV vaccination.
Thank you very much, Sister. Thank you very much. That's a very powerful question. Actually, Sister is an emblem of a mixture of science and faith, because she herself is a gynecologist. Am I right? She's a gynecologist and a sister. So they don't oppose each other. Correct, Sister? Yeah. So, and maybe, Doctor, you'd like to get that question, but before you, there's a question there. She was just trying to highlight the fact that there's good practice, but she doesn't think that there's enough guidance from the church when there's a crisis like this to say, here's what to do. There's good practice, but what about the guidance? Huh? There's Father Germain here with, in Secam, the church, and the others. Sister Agnes, not sufficient guidance.
Thank you very much. I'm Rose from Rwanda also, member of ACHA, the founder of Palliative Care Association of Rwanda, and also the vice chair of our National NCBA Alliance. I want to supplement what Sister Mbe has said. I think what's most crucial is the political will of a country. Because our First Lady is on the helm of the campaign. Again, in Rwanda, we are organized in such a way that even religious sectors, they have their own organizations. I remember when it was a peak of HIV and AIDS, and they were, that time they were promoting using of condom. If you don't use a condom, then you do. So I think the government had a stand, and even family planning. And most of the health centers and most of the hospitals in Rwanda are owned by the Catholic, by the way. There are few for Anglicans. But the government said, if you can't do it, don't oppose. If you can't agree to promote condoms in your clinic or in your hospitals, in your health center, just leave it for others, but don't go at the pulpit there and oppose. Because this is the public health issue. Because it's a public health issue, even if you oppose, who will come to be your sheep? Because you're the shepherd.
They all die.
They all die, and then what will you look after? God gave you those people to come and look after. So I think the political will plus the organization of the political organization of the country contributed a lot to what she was saying. And then they have their own organization which has its own law governing it in Rwanda, and which also they have to do what they're supposed to do as Christian, what they believe. The government will not say, because you believe in this, you have to do it. No. But again, they support the people they are looking after. Again, I think another one. Sorry?
Maybe do you want to allow your colleague to? Thank you. Thank you so much. Brenda, within a minute or 2 minutes.
Yes. Yeah. Just 1 minute or less. I want to commend the panel first for the very insightful conversations. And my question goes to Sister from Rwanda. Looking from a lens of you've been there, you've done that, and now you're looking at passing on the baton to other African countries that are starting on the journey. And you've just listened to Sister about the need for goodwill from the church leadership. And at the same time, you've heard from your colleague from Rwanda about political goodwill. What are the 2 lessons that you would give all of us in this room who are looking at going to start something in our countries? What do we need to start with in securing both political goodwill at the church leadership as well as at the community level, as well with our governments? What's the 2 lessons that you would give us that we can be able to cascade the journey and start from somewhere as opposed to starting from zero? What would you teach us? Thank you.
Thank you. Thank you, Brenda. Maybe we can start with you, Dr. Makio. In the midst of darkness and clarity around HPV, insufficient guidance from the church, even though there's practice, but insufficient guidance. You are a theologian.
Thank you, Sister from Ghana, for that question. It's true that most of the conferences of the Catholic bishops, especially in Africa, may not have given a directive apart from the initial concerns which they raised. And maybe even the Pope will not give a directive because this is not, HPV might not be a global issue. It could be regional and more so touching on Africa. So we remain sometimes in a dilemma on what to do. But we know we have had guidelines on other vaccines, for example, COVID, which there was a directive. The main concern was about the origin of the vaccines, whereby it comes from the aborted fetuses, those cells, and we were informed that there is no really formal cooperation if we have to use it, so long as there's no any other standard of care which is available for that particular vaccine. I believe in the same case with HPV vaccine, it is the only one we have at the moment. Am I right? There's no any other standard of care. Maybe we can say, okay, we can give this alternative apart from other interventions which can take place, like the screening and whatsoever. So, but on the same note, like in Kenya, the chair for the Conference of the Catholic Bishops then, Archbishop Martin Kivuva, was present when President Uhuru Kenyatta was rolling on the HPV vaccine in Mombasa. And he encouraged it and raised the same concerns which I presented at the beginning of the safety and of the other not being used as guinea pigs and whatever. But he was there during the launch. That by itself gave a clear message that maybe the concerns or the concerns which were there initially have been either cleared or scientifically been proven that by evidence that the vaccine is safety. Of course, I understand that it brings ethical dilemmas of autonomy. The church gives directives, but who at the end makes the decision? It is the individual person. You'll not hear a bishop coming to knock your door if you are married sacramentally, knocking at your door and asking you, are you committing adultery? Or are you doing this and this? They give the directive, and they expect that out of our conscience, we realize that this is right, this is wrong. We have values and principles which inform our decision making, especially when we have all the information we need and we make at the end our own informed choice. And the other issue is also conscientious objection. Those of you are in the health professional sector, you are torn in between as a Catholic. Do I now offer this person who is coming administer the vaccine or not? Do I give them this or that? It also puts us in ethical dilemmas, especially when there are no clear directives. But I think from the look of things, if those concerns have been clarified, then it means if there's no any other directive telling us not to do it, then at the moment what we have to do.
I leave that question to you.
Thank you very much. Yeah. So the church empowers the conscience, but it can do more, yeah, in terms of clarity. Sister, just maybe under a minute to build on that. Under a minute.
Yeah, I think for my sake, what I would like to propose in such gathering where we are creating that awareness, I think it's very central for the church leaders to be here. I was disappointed when I saw on the list that the bishop is not here, because sometimes, faith and science, there is a need for that clarity. So I think there is need for that joint collaboration, so that even as religious people, as Father is saying, as religion, we have to let people know the principles and know the start of the church. But we leave them to make that decision. But then again, especially as a Catholic church, we need to hear that voice from the bishops. And I think collaboration with them, like in such a forum, I think it would have really made sense, and they would have been able to give us a go-ahead. Otherwise, you can find yourself in trouble when you are proposing such. That would have been my take, in such a forum. And I would say all is not lost. I think after this, there is a need to create more awareness. The next maybe meeting is to meet the church leaders, more especially like the bishops, and be able to have conversation with them. That's what I would propose.
We have Father Germain there. Father Germain at the Secretariat of the Symposium of Episcopal Conferences of Africa and Madagascar.
Okay.
Africa and Madagascar.
Okay. Maybe he would give us an insight.
Yeah. Father, just under a minute, do you want to support, to build on what sister is? Microphone?
Yeah.
Including his neighbor there. Father
Yes, thank you for giving me the floor. So, in the light of the church teaching, especially in the documents published by the Pope Benedict XVI, when he was the prefect of the dicastery of, what do we call science and religion are not enemies. I agree with you. I reiterate that what is said, and there is a complementarity between faith and religion, in that sense that both they search for the truth. But the reservation of the church about the science is the consequence of abuse of the power of the reason, especially the abuse of the principle of the rationality. If you teach the philosophy, remember the principle of Hegel. Always the real is rational, or that is rational is real. So it is a dangerous, this principle, because it is a negation of transcendence. So this is one of the abuses of the scientific research. So, but the church is not against the scientific research, but what is important is the respect of the human dignity, the respect of the life, because it is the important values for the Catholic Church and based on the sacred scripture. And about the vaccine, in the light of this principle that I mentioned, there was, as far as I know, no objection about the research about the vaccine at the time of the COVID. And there was maybe a reservation from some groups, but the church didn't publish any declaration about this. But the reservations of the church concerns of the use of the medicines and the cost of the medicines, because there is a principle in the social teaching of the church about the option preferential of the poor. The poor must be the priority of the policy of the government, and the priority of the pastoral of the church. But if we develop a scientific research in order to compete with the other multinationals in the pharmacy, it is contrary on the principle of the church, because there was a competition between the companies about the research of the vaccine, but the vaccine itself is not bad, but the use, it is in the moral, the ethics, it is the use which can be considered as bad, because the means, we cannot justify the goal with the means. So we must, how do we call combine the two words, the means and the goals. The means is the good means, and the goal is the life, the respect of life, the respect of human dignity. And about the beliefs in the culture, maybe you have heard at the time of the COVID, the experience of Madagascar, this famous drink promoted by the President of the Republic, and he sent many bottles of this drink to Africa, in Ghana. Yes, there was a container, one container. Yes, he sent this drink in Chad, in Ghana, and in Cameroon. There was a controversy about this. Where a researcher, a professor of medicine, says it is a product of a superstition. But as far as I know, the Bishops' Conference didn't publish a declaration about this. But there were 3 bishops who drank this, and because one of them got the COVID, and he said that he was healed. And the president asked him to give a testimony to the people. My drink is efficient. So this is, for me, no, we cannot do this because you are manipulated by the politicians. So, but I don't criticize the bishop, but because in front of the disease, you try to find all the means, and as you know, we have some plants, so which are efficient. Thank you.
Thank you so much. I think that's powerful. The Reverend Father was just highlighting the link of reason and faith, and warning us against fideism and rationalism. The isms, fideism, too much belief in faith alone, sola fide, no, or sola science. The two work together, and then he dwelt on a topic very close to your heart, which Haiti also works for, the need to promote local medicines, that the West is not the sole proprietor of knowledge. And this is what we should advance. Maybe to begin to close, Sister Mubiei, under 1 minute, you had comments from Rwanda. Just under 1 minute, sister, and then we get a parting shot for.
Thank you. Yeah, thank you very much to my colleague from Rwanda. You understood that there were many factors for us to succeed in that cervical cancer. So, lesson learned. I can say about 2 lessons. First of all, a strong partnership, collaboration between the government, religious institution, and the community organization has been a cornerstone of the campaign to succeed. Because I remember what the church has been telling us, that protecting one's life is a moral responsibilities for everyone, deeply rooted in faith. And also I can say another lesson is, if we need to build a trust in community, we need to utilize religious leaders, because according to what I have learned, utilizing religious community leaders to address a cultural and religious concern has enhanced community acceptance of the vaccine. It's what I have learned. And also, if you need to learn more, we kindly invite you to come to learn from our experience. We will be very happy. Thank you very much.
Thank you, Sister. Imam, we are concluding. Maybe under 30 seconds, just a parting word to the congregation.
OK.
Just a final word, un petit mot.
Oui, j'ai compris.
Moins que 30 secondes.
OK. Donc, ce que je voudrais, c'est qu'il y ait une grande clarification des acteurs de la médecine auprès des acteurs religieux pour qu'ils soient édifiés sur le caractère objectif scientifique de la maladie. Et maintenant, nous pourrons sensibiliser. Voilà.
So one of the key issues of this panel was to seek this reconciliation. That's what is highlighting, that if there is increased illumination and clarification about the issues between science and faith, if there is that clarification, that would do the best. Princess, one last word.
Thank you, Father. Okay, as I said before, that this was my first time in working in the health sector. But as a young African leader, I'm willing to learn from this, and then I'm willing to give 100% for young girls to vaccinate.
That's a lot of humility, Princess. Thank you.
Thank you.
Thank you. Sister Mubiai, one last word. One last word. She doesn't have Daniel anymore. Sister Mary, pastoral theologian, one last word to the community.
From the question of sister, that the church is in support, because during Vatican II, it gave us a document that we call Pastoral Constitution on the Church on Modern World, the things that are happening today.
In the modern world.
Yes, and in that document, the church insisted that we don't need to stick only to theological principles, but we also need to bring in the secular sciences. And it is through these secular sciences that we are able to learn who the human person is well and understand that person well, and we are able to give a way out. And so as my conclusion, I say that we need to look at all sectors, be it cultural, be it political, be it social, so that we can gather out the needs that we need to look at as pastoral agents. And looking at those needs, we also need to illuminate them, to look at them in the light of faith, because even when you read the word of God, it says, God says, I have observed the cry of my people. So what next? What do I need to do? And it's a call that we all need to make people aware, to help people to understand what are these terminologies that we are using. What is the purpose of this vaccine? Because the human person, the person we are talking about, is really dipped in the cultures. And during one of the communications, Pope John Paul said, man, of course with women, yes, of course with women, man is of culture, is about culture, and is for culture. And therefore, man is the culture. Meaning that you cannot cut this person from that, and you need to really sit with this person to help this person to understand, why should I not follow that and not this? So once we make people aware, once we have, as a church, forums that can help people to understand why to stick to this and not to this, I think these things will be well. Because the vaccine is not bad, but what we hear, the communications that we have. And so we need also to have communication strategies as well as communication principles that can help us to help people to come close and understand what is happening today.
Thank you, sister. Thank you so much. Dr. Pascal, a parting shot, just a parting shot.
The unity of science and faith does not necessarily mean that we don't have diverging ideas. What we need to do is to focus on the common goal without compromising the values of faith and the scientific truth. There are many things which are technologically possible, but not ethically acceptable. So when there is good science, there is good ethics. And even when there is good science, let ethics also journey in synodality with technology. Thank you.
Thank you. That's powerful. In line with what Father Jimmy was saying, the respect for life, for the dignity of the human person. Yeah. Our woman theologian, the very last word.
Okay, my final parting short one, I want to call for collaboration between faith and science. There's a need for that collaboration. And then I also want to propose there's a need to address, we have race, religious, and cultural factors. I think they need to be addressed if this vaccine is really going to have a positive uptake, so address those challenges. And then also there are so many mistrusts between science, government, and faith. So there's also a need to create that trust between the two partners. And also in doing medicine or whatever we are to do, I think I also want to repeat the issue of promoting life, that we have to ensure that we promote that culture of life and especially respect the human dignity and respect the autonomy, especially if someone says no to that vaccine, let that be respected, the autonomy. But that is if they have been able to be given informed decision and they have been able to get the informed consent, then we need to respect that. And again, let us also be guided by our conscience. Thank you.
Thank you very much to our experts for helping us throw light on the issues concerning faith and vaccination, faith and science. That was very, very eloquent. Thank you very much to you. Thank you to the Assembly for following this conversation, and I'm sure it throws light on more what we are going to discuss in the coming couple of days. Thank you. Shall we applaud them? Thank you. Thank you. Thank you. Thank you. Thank you. Asante.
Thank you very much. All right. Thank you. Thank you very much. That was a very insightful session. I believe we at least have an idea of the 17 Sustainable Development Goals, yeah? Hello. Give me a hello. Hello, everybody. Yeah, I know we're quite, it was very heavy. The content that we've just come from is very heavy. So thank you to our panelists and to our moderator. We are going to the next segment of the program, yeah? Breakout sessions. And I was talking before that, I was talking about the 17 Sustainable Development Goals, and SDG 17 is about collaboration and partnerships. And I've had a lot of that in the conversations we have been having throughout the day, yeah? Okay, give me a number one. A one, a clap, a snap, a two. Then now I have your attention, finally. Great, so we're going to our breakout sessions. Maybe Father Charles will help us with that for the breakout sessions. We have 3 breakout sessions. The first one will be handling thematic problem definition and analysis. Now, everything you feel like is something we need to look at thematically is going to the first session, the first breakout group. And then we have knowledge collaboration, which of course we've talked about a lot. How do we bridge science and faith in HPV vaccination? And then breakout session number 2, that was breakout session number 1. Breakout session number 2 is community-centric advocacy for HPV vaccination, that is identifying challenges in Africa. What are the challenges that we have? We've already had a conversation about that a little bit, so we're going to delve deeper into that. Now, breakout session number 3 is enhancing access and uptake of screening and treatment for cervical cancer. So each breakout session will have 2 lead presentations, so you'll get to know who your presenters are in your breakout sessions. Okay? Come on now, okay? So, yes. Great. So as we prepare for that, let's take a 5 minutes break because I know, just stretch, walk around, catch up with whoever you're sitting next to just get insights on what we were talking about. So 5 minutes and then we can go to our breakout sessions.
So Esther is going to either send the names to our emails or project them here. The groups are already made. And we are going to be in the group discussion for like an hour, 15 minutes. And we will be back here. This is 3 something. We'll be back here at, we'll break for tea at 4:30, okay? And then we'll be back here at 5 for a plenary discussion and reporting and plenary discussion. And I know that many of us have issues that they wanted to sort of share in the plenary. There'll be an hour, a full hour for us to sort of discuss. And then at 6, when we finish, the sisters, the Catholics, the priests, they will have prayers. They will have a mass here. And just in case you want to pray with them, you are welcome. Yeah? Otherwise, it will also be downtime. Yeah. Thank you very much. Take over.
All right, so on screen, we have Group 1, or Knowledge Collaboration, Bridging Science and Faith in HPV Vaccination. So Esther is going to guide us on where we'll go to different rooms. All right, so looks like we'll still have the groups here. Apologies, but group 1, you will be on my left. So this side is group 1, then in the middle, group 2, and on the far right, on my far right, group 3, okay? So group 1, yeah, so we will, sorry? Yeah, so group 1, group 2, and group 3. Yes. So we screen is group 2, community-centric advocacy for HPV vaccination, identifying challenges in Africa. So check out for your name. In case you need any clarifications, please, you can ask Esther right here. So group 3 is on screen, enhancing access and uptake of screening and treatment for cervical cancer. So give us 5 minutes to sort a few things out. Apologies.
Is an important occasion for the Catholic Church, emphasizing the vital role of families in nurturing faith and values. Join us for the Archdiocese of Nairobi Central Ordinary Family Day on Saturday, June 15th this year, at the Shrine of Mary Help of Christians, Upper Hill, Don Bosco, starting at 9 a.m. This momentous occasion will be presided over by His Grace Philip Anyolo of the Archdiocese of Nairobi. This year's theme is Sin and its Negative Impact on Active Participation in Christian Life. Capuchin TV will bring you this celebration live and across our various social media platforms. Congratulations, Central Deanery, as you mark your family day this year. May the good Lord bless you and help you overcome challenges to grow stronger in your spiritual journey.
Let us live our faith with courage.
Happy Family Day, Central Deanery from Capuchin TV. Keep watching Capuchin TV, your Catholic identity channel.